there.
No kidding.
Wow. Yeah.
And I know we had one of our trucks over there. I know Bob Doherty and Matt O'Connor went over today.
Yeah, from Action.
Yep.
Yeah. I think the paramedic that works with him today was his son Sam. He's a new hire at the track on the rescue crew with us. So.
Oh, really?
Yeah.
Yeah, that's
Yep.
Bob Doherty was there today.
Yep. Yep. I think his son Sam. Yep. It's cool.
All right, y'all. Looks to be 6 o'clock. I just started recording. So tonight we're going to start with airway management. Super important topic tonight. So make sure you're paying attention. We're starting to lay those groundworks for actually treating patients here. Let's see, slide 2. All right. This is the competency. This is what you're going to be tested on. This is what you need to know. So as an EMT, you need to be able to apply knowledge in general anatomy, physiology, and management of airway, mechanical ventilation, and respirations for all age groups. And as we go on, we'll touch base on each of these. If you have questions, feel free to stop me. We can chat about it, or if you need some examples, just let me know. So tonight, we're going to touch base anatomy, airway assessment, and techniques to assure a patent airway. And do you all have the slides that you're following along with as well? I know Tina did, but all right, perfect. If there's anything that you need clarification on, just feel free to stop me. So let's start with respirations, the anatomy of respirations, how physiologically and pathophysiologically respirations work, and how we get the other night when I was talking about how we have oxygenation, we have ventilation, we have respirations, and how basically the ventilations are your mechanical, respirations are more, and oxygenation are more on your chemical and cellular level. And then again, we're going to talk about assessment and management of inadequate ventilations and how we do supplemental oxygen and the devices that we use to provide that supplemental oxygen. Again, this is just telling you that you need to know about assessments, artificial ventilation. So artificial ventilation is when we ventilate for a patient with different devices. We're going to talk about minute ventilation, which is basically the rate that we ventilate, and kind of go into more of the anatomy of that. And the pathophysiology, again, applying those fundamental knowledges of pathophysiology of respiration and perfusion. So basically, as far as all these competencies go, they need to make sure you know how to breathe for someone else, the science behind it, and how it all works. And we're going to kind of deep dive. Yeah,
Zach,
absolutely.
Has anyone else lost the slide presentation?
No.
No, I still have it.
I still have it.
Oh, there it is. I'm sorry, it's back.
Oh, you're good. No, you're good. All right. Here's the introduction. Again, for like the third time it's said in this slideshow, we're going to be talking about how to make sure people are breathing adequately, what happens if their breathing is disrupted, how we do that oxygen delivery and how the body normally does that, and then how oxygen reaches body tissues and cells through breathing and circulation. Respiratory system, cardiac system work together to make that happen, and we'll touch base on all of that. So for anatomy, you all have been doing a lot of anatomy and terminology over the last few days. This is kind of going to be a deep dive into the airway anatomy. There's a figure here. You guys can refer to your slide in your book for that, and we'll kind of deep dive in here to that. The respiratory system consists of structures that make up airway and to help us breathe and ventilate. That's kind of self-spoken there. The airway is divided into the upper and lower airways. Now, this is super important because different diseases, different issues can affect different airways. So sometimes it's an upper airway issue, sometimes it's a lower airway issue. And we'll touch base on that further on in this presentation. But it's good to know that there is a divide between the two. So as far as the upper airway is concerned, you've got the nose, the mouth, the oral cavity, the pharynx, and the larynx. The upper airways main function is to warm, filter, and humidify. I would highlight that and remember that because that is a test question. I guarantee it. especially on the National Registry. The upper airway's main function is to warm, filter, and humidify air as it enters the body. The pharynx is the muscular tube extending from the nose to the mouth to the level of the esophagus and the trachea. It's composed from top to bottom of the nasal pharynx, the oral pharynx, and the laryngeal pharynx, which we'll learn here soon that there's a device that you can place in each of those to help with ventilation. Bear with me here, slideshow's not wanting to move forward. All right, here's another picture of that anatomy. You can see the nasal pharynx, the oral pharynx, and the laryngeal pharynx. Not the best picture. It's kind of hard to get a grasp of how that all works, but basically that is the back and roof of your mouth. The nasal being at the top, oral and the larynx going down. And again, it's warming, it's humidifying, but it's also filtering out small dust and small particles. All right, the oral pharynx. This is the posterior portion of the oral cavity. So if you open up your mouth, that's the very back of your mouth. The epiglottis, which kind of looks like a thumb, sits back there, and it's superior to the larynx. So you've got the uvula that hangs down. Back behind that, there's something called the epiglottis, which is a little flap that blocks the trachea when you're eating or when you stop taking a breath in. That's going to be above the larynx. And here's kind of a diagram of that. You can see on the side cutaway where that epiglottis sits, as well as how each pharynx is laid out.
So, Zach, can you go back a slide?
Yeah, absolutely.
So some landmarks you guys are really going to need to know. Trying to see it on here. But
Yell
you
them out.
show where the hard palate is.
Hard palate, yeah, right through here.
So the hard palate going into the soft palate, which is just behind the hard palate, is going to be a landmark when you're utilizing oropharyngeal airways. So I want you guys to have an understanding of where that goes. If you take your tongue and run it on the roof of your mouth, you'll feel hard to soft. You can actually feel that with your tongue, right? And the other thing too, the little punching bag thing in there in the middle of the airway there, the uvula. So something else to be familiar with that is when we talk about epiglottitis and things like that. We'll get more into those in that region. We can start getting more into pediatrics and how dangerous that can be as well. So it's really important to understand the upper airway anatomy and what we're doing, along with also looking at, we're going to get the nasal cavity here shortly, but the nasal cavity and how you place nasal pharyngeal airways, and looking at more of like where the skull is located, like the base of the skull, and if we have that type of fracture, which you mentioned before in patient assessment on Tuesday, looking for that battle sign and things like that. So.
And just to kind of add on, your tonsils also are going to sit right here. So people with tonsillitis, you'll see some swelling through here as well. All right, anatomy of the upper airway. So we've already been kind of hitting on this, but this is the larynx. It's a structure formed by many independent cartilage structures. So no bone, but a lot of hard cartilage. And you can kind of feel this if you guys palpate your own throat. You can start feeling some of this anatomy, okay? The trachea, the trachea is going to be made of those carotid rings. So you can actually feel those rings if you run your finger up your neck. You can actually feel each of these structures. So a good way to kind of learn these is just start palpate them on yourself. Again, this marks where the upper airway ends and the lower airway begins. The larynx is where, like I said, that thyroid cartilage forms a V. The thyroid cartilage is the first ring of the trachea. So if you follow that ring all the way up, you'll feel it turn into a bigger section. That's where your larynx starts and your thyroid cartilage begins. The glottis is the area between your vocal cords. You're not going to be able to feel that, but it's in the back of that larynx. Now, for as far as the lower airway, so that's everything below that first trachea ring, okay? That's going to continue on to be your trachea, your bronchi, and your lungs. The trachea. basically that's your breathing tube, your own body's breathing tube. It's a conduit for air into the lungs. It divides the carina into two main stems, the bronchi, which goes to the right and the left. The right sits a little higher than the left, which will be important later on in your medical career. So just kind of a side note there, that your right is right above the left side. So if you were to put anything down the trachea, it's going to go to the right first because that's the highest exit first. Bronchi are supported by cartilage, and the bronchi distribute the oxygen between both sides of the lungs. And here's kind of a picture for those people who need that visual. You have the carina right there at the split, and the trachea right above it, and that's what feeds into each lung. As you go to the lungs, those bronchi start as the main, they go to a smaller bronchi and then into bronchioles, which then will hit the alveoli, which we'll be getting to in the next couple slides. Those bronchioles are made of smooth muscles in between those cartilages. Smaller bronchioles are connected to the alveoli, and then the oxygen is transported from there back to the heart and distributed to the rest of the body. So you go upper airway, lower airway. The lower airway's got the trachea, which then goes down to carina, into the bronchioles, that then go all the way down to the alveoli. That's how air flows. And that's important to kind of know that process, because different disease processes will affect different parts of the lower airway and the upper airway. And again, here's more of the anatomy of the lower airway. The heart and the great vessels are found all in this thoracic cavity. The lungs kind of lay on top of the heart and kind of all wrap around it. So everything kind of works in conjunction. The other day we were talking about how the diaphragm sometimes helps pull blood into the heart. It's all a musculature that works together. The thoracic cavity contains the important atomic structures for ventilation, oxygenation, and respirations. We know that the thoracic cavity is where we have the lungs and the heart. That's pretty general information. The vena cava and the aorta also sit behind the lungs. So you can kind of see in that diagram how that works. Does anybody remember for ventilations, is it passive or active to take a breath? Anybody remember?
I think it's
You have to
active.
Okay, yeah. What about, is it a negative pressure or a positive pressure? I think I heard
Negative.
Tina. Yeah, good. All right. This can be demonstrated using a bell jar. So basically, if you were to have a jar, you were to pull a vacuum and you have two balloons, those balloons would fill. It's the same concept. Again, you all have seen videos of this. If you want further demonstrations, I can give you some links on, basically it shows how breathing works. But basically, in theory behind it, the diaphragm drops down, that creates a negative pressure, which then pulls air from the outside, which is a higher pressure, down into the lungs. Kevin, you got anything you want to add on to that? All right. The mediastinum contains the heart, the great vessels, the esophagus, the trachea, the major bronchi, and many nerves. So this area of your body, I don't know if you all can see me or not, I'm a big visual person. So this has a whole lot of junk. Any type of injuries or illness that affects something in your chest affects a lot of different things besides just your lungs or your heart. It's all kind of intertwined with each other. And that's kind of what it wants you to know here, is that everything lies, a lot of vital organs lie in this mediastinum. All right, here we go into more of the physiology of breathing. The respiratory and cardiovascular system work together. And this is, again, we're kind of getting deep dive into what we talked about the other night versus ventilation and oxygenation and respiration, how all of those tie together. So the respiratory system ensures a constant supply of oxygen and nutrient is delivered to the cells, and the blood carries that oxygen, and then it carries the carbon dioxide from those cells out. Our lungs breathe that waste product out. All right. How's everybody doing? Everybody tracking so far? All right. So the physiology of breathing, ventilation, that's that mechanical drive, the physical act of actually breathing air in, or if you have a patient that you're giving that air to, you're pushing it into their lungs and then breathing it out. Oxygenation is the process of that oxygen being loaded onto hemoglobin. Okay, this is where it gets a little tricky because of the difference between oxygenation and respiration. Oxygenation is simply oxygen molecules binding to hemoglobin. Respiration is the exchange of oxygen and carbon dioxide in the alveoli, as well as the tissues in the body. So ventilation, easy. It's the mechanics behind it. Oxygenation only does or deals with how we oxygenate the molecules of the hemoglobin. If you think oxygenation, oxygen, it's a good way to kind of remember that. Respiration is the whole cycle, how we get oxygen to the cells from the alveoli and how those cells and those tissues get the carbon dioxide back to the lungs. Any questions on that? Clear as mud? All right. So ventilation is a physical act of moving air. I've kind of beat that like a dead horse here. It's the active muscular part of breathing. The diaphragm and the intercostal muscles contract. This generates that negative pressure in the thorax, which allows the air to enter. I think we've touched that a few times. Everybody understand that? Cool. The lungs that require the movement of the chest and supporting structures to expand. Partial pressure is the amount of gas in the air or dissolved in fluid. Oxygen and carbon dioxide both diffuse until the partial pressure in the air and the blood are equal. All right, let me make that a little simpler to understand because I kind of just drop it in here. Hold on, somebody's joining. So the way this works is your blood, let's say your blood to hemoglobin is like 4 pennies, right? In your lungs, and you have 4 pennies on the outside of coming in. So if you have both 4 and 4, it's equal. Now, we all want to have more money, right? So let's say the lungs now have 8 pennies, but our bloodstream only has 2. So what the body is going to do when we breathe, that partial pressure is going to equalize where we have equal parts in both the lungs and the blood. Does that kind of make sense? The cycle is always trying to equalize what gas is in the air and what gas is in the lungs or dissolved in the blood. Make sense? Okay. All right. Again, we talked about the diaphragm. This is just a picture of that. Diaphragm relaxes. The lungs kind of exhale. That is a passive movement. The diaphragm taking a big breath in is going to be your active movement, and that's just demonstrating with the balloons and the bell or your chest. Inhalation delivers oxygen to the alveoli. That's your tidal volume, the amount of air coming in, the volume of air you're pulling. And then dead space, which I'm sure we'll touch on in just a second. Dead space is when you take a breath and you exhale, there's a certain amount of air that's not going to make it out of your lungs. That is dead space. It's air that kind of sits idly in your airway. So your upper and lower airway, you can't breathe it out, you can't breathe it in, it just kind of sits there. Exhalation does not normally require muscular effort. Like I said, that's that passive process. The diaphragm automatically just kind of slowly retracts up. Anybody heard of abdominal breathing? We'll touch on that later on. But if you have someone that is not breathing on their own, sometimes you'll hear, let's say someone's in cardiac arrest, you'll hear a sigh or an exhale. That does not mean they're breathing. That is the body just relaxing and causing air to be forced out. That's that passive process. Regulation of ventilation involves a complex series of receptors and feedback loops. Failure to meet those needs for oxygen may result in hypoxia. pH changes in the blood and the cerebrospinal fluid can also cause different ventilation rates. Hypoxic drive, which is this drive that the body or the brain doesn't think it's getting enough oxygen, it will increase your respiratory rate. It'll do funny things with your respiratory rate. And you can see that with a lot of COPDers. They're tachypnic or breathe in fast. They live in a pulse ox below 94 usually. We talked the other day about sick people who got the flu or got some type of illness that causes them to breathe really fast. That's usually that change in the pH of their body. That change is what causes the brain to say, hey, I need to breathe faster to breathe some of this acid off. Those are those receptors and feedback loops working in exchange with your body, moving those gases and those acids around. Oxygenation, like I said earlier, is the process of moving those oxygen molecules onto hemoglobin. It's required for internal respiration to take place. Just because the oxygen is on the hemoglobin doesn't mean that respiration is actually taking place. Ventilation without oxygenation can occur where oxygen levels have been depleted. So there's no oxygen, even though you're ventilating, you're not going to be oxygenating. Kind of makes sense. No oxygen, you can't oxygenate. Respirations are the actual exchange of the oxygen and carbon dioxide. We already talked about this. That is the chemical exchange of when we breathe in, we're putting oxygen on to the hemoglobin, but it's also when we are exchanging that CO2 to be breathed out of the body. Cells take energy for nutrients through that metabolism. And again, we're talking about respirations here. External respirations brings fresh air into the respiratory system, exchanges the oxygen and carbon dioxide between the alveoli and the blood. Internal respirations is the exchange of oxygen and carbon dioxide between systematic circulatory system and cells. So external, what we normally think of breathing, right? Internal is when the cells themselves are offloading or taking up oxygen. Clear, everybody? All right. Any questions to this point? All right, the pathophysiology of respirations. This is kind of how all this works. Well, we're going to deep dive in even deeper. Chemoreceptors monitor the levels of oxygen, carbon dioxide, hydrogen ions, and pH. So again, those are those receptors that are constantly running in your brain saying, oh, my acid is high, I need to breathe faster, or oh, my oxygen's low, I need to breathe in quicker. This is how all that stuff kind of comes into play. Ventilation and perfusion ratios and mismatches. Air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. Failure to match is the cause of most abnormalities of oxygen and carbon dioxide. So basically, you have these cycles and they have to have a ratio. They have to work together. If either one of those gets off, it throws off either your oxygenation, your CO2, your respirations. If they're not working or copacetic, you're not going to get proper exchange. And that's kind of what it's saying here. Gas exchange does not take place. Lack of oxygen in the bloodstream. CO2 is recirculated, so it's not breathed off, and you can end up with severe hypoxemia and, low blood hemoglobin can also cause this. All right. Factors affecting pulmonary ventilation: infections, allergic reactions, unresponsiveness, and some trauma. So we talked earlier, you took your tongue and you took it across your hard palate to your soft palate. Now, if you're laying on your back, you're unconscious, your tongue has a tendency to fall back. You ever heard anybody snoring? Most of the time, that's that tongue partially occluding their airway. Now, if you got somebody with a giant tongue who's unresponsive, be it an overdose or a cardiac arrest, that tongue completely blocks that airway. So even if you were to breathe for them, you're not going to be able to get air in because of that tongue. An overdose, they might be passed out on their back. They are breathing, but their tongue gets in the way. They're not going to adequately be able to oxygenate themselves. So the tongue can be very problematic, and that's something to remember when you go to take care of these patients is airway positioning, which we'll touch on, but different adjuncts or devices we can use to negate those. And we'll touch all of that here in just a minute. Factors affecting respirations, we have, again, atmospheric pressure, partial pressure, and then internal would be pneumonias, pulmonary edema, COPD. So again, these are all different things that can affect respirations. As far as circulatory system, so again, they said that breathing and your circulatory system kind of work hand in hand. These are some things that in the circulatory compromise that can cause this. So a pneumotension, a hemothorax, or hemopneumo, are all things that can affect that oxygenation process. All right. Anybody need a break? I've just dumped a bunch of information on you. Everybody good? All right, we'll keep moving then. Again, they're harping on this circulatory compromise, but blood loss, anemia, hypovolemic shock, vasodilatory shock, pretty much any shock can affect your respiratory rate. So this is a little, we've now moving into the assessment, how we assess that airway. And I guess this is something they want you to be aware of as far as some of the risk. So AGPs, or aerosol generated procedures, are procedures or things that we do that can cause spray from the airway. Every time we breathe, we cough, we sneeze, microparticles of mist, of all those wonderful germs, are being spread everywhere. Okay, so anytime we're doing CPR, nebulizer treatment, everyone know what a nebulizer treatment is before I get too far in? Okay, nebulizer treatments, anytime we intubate or we take someone's airway, either be a supraglottic airway, which you guys will learn, or an actual intubation, or anytime we're providing any type of positive pressure, there's a risk that that mist can get on you. Now, if this patient has COVID or any type of respiratory illness, that can get you sick. So the proper thing here is A, recognizing that, but also proper PPE such as mask and protective eyewear. Any questions on that? All right, so these are important. So I definitely pay attention here. Adequate breathing for an adult, breathing between 12 and 20 times per minute. You want your patients to have a regular pattern of inhalation and exhalation. You want both lungs to be clear, which you all will learn in your skills labs, how to assess lung sounds, and then to sound equal. So they might be clear, but one sounds a little less than the other. It's called diminished. You want to be able to identify that. You want to physically be able to look at their chest and see that their chest is rising equally on both sides and then falls equally on both sides. And again, while visually inspecting that, an adequate depth. I will tell you, assessing adequate depth on a real patient is not easy by just visualizing them. And that's why we have different tools in the field to assess that. All right, abnormal breathing, fewer than 12 breaths a minute or more than 20. Irregular rhythms, which we'll touch base on a few of those. Diminished, absent, or noisy, auscultated breath sounds. Reduced flow of expired air at the nose and mouth. So, little side homework for you. If you get a chance, go onto YouTube, type in lung sounds, and go ahead and start learning some of those lung sounds. There's a bunch of different ones out there. The quicker you can learn to identify that, the better it would help you in your career. But knowing what normal sounds like, knowing what bronchi or, sorry, I'm trying to think of another one here, bronchi or coarse grinds or things like that will be something to help you later down the road. Again, more things about recognizing abnormal breathing, inadequate chest expansion, increased effort of breathing, shallow breathing. If a patient looks sick, they look blue, they look cool, they look moist, they look like they're tired or struggling and breathing really hard, that's not a good sign, especially in an adult. It means we're almost at the point where we're going to have to start really helping their airway here. Skin pulling around their ribs and above their clavicles. So those are called using your accessory muscles. So I'm sure, you know, if you all have been around the medical field or you've watched the medical shows, you'll see those people, COPDs especially, where they're so thin and you see all those muscles in their ribs and their neck and their stomach all fighting to help someone breathe. That's that accessory muscle use. And it's really, you'll know it when you see it. But if you see someone using those accessory muscles, they're really struggling to breathe, and it's important that we address that pretty quickly. A patient may appear to breathe after the heart is stopped. Those are those agonal gas that I was talking about. So that's that diaphragm relaxing and that breath just being forced out from that passive expellation of air. Here's a test question for you. Those Cheyenne stroke respirations are often seen in patients with stroke and head injuries. I guarantee you, if it's not on one of these tests, you will see that again. basically, to identify it, Cheyenne stroke express are irregular respirations followed by a period of apnea. So you might have a bunch of breathing really fast. It may be slow, but all of a sudden they just stop breathing. And then they start that same cycle over again. That is Cheyenne strokes respirations. And I guarantee you, you will see that again. Something to note, head injuries and strokes are one of the biggest times we see that. All right. Let's see here. Ataxic respirations. Those are those irregular or undefined patterns. Again, maybe followed by a serious head injury. So if they're just breathing all sorts of random rhythms all over the place, there's a good chance that there's a head injury associated with it. And I would, again, these are important. So if you're taking notes, I would highlight each one of these. Kussmaul respirations. These are deep, rapid, rapid respirations. It's a really fast. And what it is the body's trying to breathe. Sorry, I'm serious, having a fit about that. The body's trying to breathe off a lot of acid. When we normally see this, and it may say this further in the slide, is people who are in DKA or have high blood sugars and stuff like that. That body is trying to get that acidosis off. That's when you're going to smell that fruity smelling breath sometimes. When they're breathing this fast, it really kind of perfumes the air. Again, we're going to adjust this pretty rapidly. It needs to be treated immediately. All right. How to assess respirations. Even though a patient may be ventilating appropriately, respirations may be compromised. So just because it looks like they're breathing normally doesn't mean that cellular, that low level kind of microscopic view of oxygenation is actually taking place. That respirations might not be working. A good way to know this is even though they're breathing, if they're acting different or they have a level of consciousness that's not normal, or they're cyanotic. Everyone know what cyanotic means? So blue, kind of like my shirt. I've seen people literally as blue as my shirt here. That's a good sign that even though they're breathing, that they're not oxygenating or having proper respirations. Again, considering oxygenation. Some tools we can use. Pulse oximetry is considered a routine vital sign. Everyone know how we do a pulse ox? It's a little thing we stick on the finger. It's got the red light on it. Okay. What that is doing is it's measuring something's attached to a hemoglobin. It does not mean it's oxygen every time. It means it sees something attached to hemoglobin, which most of the time that should be oxygen. But there are times that we'll talk about later that different things can attach to that hemoglobin to cause that to give you a false reading. But 99% of your patients, so you put a pulse ox on their finger, that's what you're going to see is their oxygen saturation of that hemoglobin. Make sense? Now, this is new, even since I started my career, end-tidal CO2. So what we're doing is measuring the amount of CO2 on each exhaled breath. Now, we have these fancy things now called waveform capnography, which you will learn more about. And that's how basically when somebody exhales, we actually track on a graph how that capnography is shaped. This is a new tool for EMS, and it's been life-changing for our career in the last 8 years or so. And I think Morgan would agree that it's really changed how we treat patients. Low CO2 levels we see for hyperventilation. Anybody know why that is? Think about that. If someone's hyperventilating, why would their CO2 be low? Anybody? Lisa, I think you're muted. Or Tina, I'm sorry.
They're blowing it out. They're blowing out all the CO2.
Absolutely. So, like I said, there's that balance, right? We have to keep that good balance. If you're breathing so fast, you're just going to be blowing off all that CO2, which is going to drive that down, make you acidotic. That's why, if you all ever notice, when somebody hyperventilates, they usually pass out. The brain is starved for oxygen. It says, hold on, we need to restart. Good night. You wake up. If you ever notice, they start breathing normally for a while until whatever causes them to hyperventilate kicks back in. But that's why people pass out. They drive that acid base down. The brain says, I don't have enough oxygen. I'm going to do a complete reset, see what happens. Low CO could also be caused by decreased returns to the lungs. So there could be some type of obstruction or just reduced CO2 production at the cellular level. High CO2 on the other side is poor ventilations or apnea. So if someone's not breathing, their CO is going to build and build and build and build and build. All right. We use CAPNO, or I have a hard time saying the whole word. I get tongue twisted. So we're just going to say CAPNO for right now. If Morgan wants to jump in and try to get that word out. Capnography and capmetry. Yeah.
Oh, I don't know about that one.
Yeah.
Capnometry.
Normal range. Capnometry. There we go. Sound it out. Fixed on phonics. Normal range is 35 to 45. I would highlight this, write this down. This is a vital sign that you will know for the rest of your career and you will probably be tested on. A normal range for end tidal is 35 to 45. Can be used spontaneously breathing patients with a special nasal cannula. Everyone knows what a nasal cannula is, right? Well, they make these fancy ones that cost a couple dollars more that you plug in your monitor and it gives you this end tidal reading without having to do anything invasive to the patient. Sits right on their nose. It sucks in some of their breath that they exhale and gives you a reading. And most people refer to those as a end tidal nasal cannula. Which I had one here, but I think I left it in my work bag. All right. Anybody need to take a break?
So Zach.
Yeah.
Yeah, I'm just going to kind of add to that. So end tidal CO2, pulse oximetry. All right. What is the difference between the two and what do they measure?
Tina's
Well,
got
the
her
question
thinking
to the
cap on
class.
here. Right.
Well, the
What about
CAPNO,
Go ahead.
the CAPNO is actually measuring the end tidal, so it's giving you an
Okay.
accurate. The oximetry is actually just telling you that something is attached to your hemoglobin. Hopefully, it is oxygen. But it's more of an internal. It's it's measuring it differently.
Kind of. Okay.
Right, so-
go ahead,
No,
Kevin.
so
You want
wait,
me?
no, we can both do it together if you want. So, but what it's really looking at is two things. Capnography is measuring perfusion.
Oh,
Pulse oximetry is measuring oxygenation.
yep.
They're completely different, but they play hand in hand, right? And here's a cool little trick, and we'll show you guys this stuff here in your practical sessions. You can put a pulse, so I'll use Zach as an example since Zach's here as one of the instructors. If Zach were to put a pulse oximeter reading on a cardiac monitor and put it on his finger, I'm hoping that his pulse oximetry will be between 99 and 100%.
Let's see.
That's the
I can
plan.
do it right now. Let's see. It said 97% 10 minutes ago. So
Right. So, yeah. Oop, wrong button.
But isn't the pulse ox delayed?
it
And
is.
that's what I'm going to get in, and that's what I'm going to get into.
Oh,
So-
sorry.
No, you're fine. You jumped ahead of me, which is good. At least you're thinking about it. End tidal is at that moment perfusion status. Oxygen, I'm sorry, with off-gassing carbon dioxide. So we look at capnography and we look at that waveform. If a patient became apneic, okay, and they stop breathing, no longer breathing anymore, right? You're going to go from end tidal between 35 and 45 right down to 0. You're going to get an apneic alarm within 30 seconds. Now, with pulse oximetry, even with a patient who is unresponsive, not conscious, not breathing, will still show a pulse ox reading of 99%, and it will hold that for minutes upon minutes. And then you'll start seeing it decrease slowly. So there is that delay. Real-time respiration, real-time perfusion assessment is done through end tidal CO2. I am going to take a lecture with you. I'm going to put a lecture to you guys sometime in the future here when we only have one lecture going on. And if we have time tonight and I can get it done, I'll try to throw it in there. But it usually takes about 2 hours, right? And it goes in depth on waveform and capnography and the differences between oxygenation, and perfusion. I put together a program with that. So I want you guys to have an understanding with this, and again, you will be tested on it. There's a difference between perfusion and oxygenation, right? So Zach, I don't know if you want to go any more in depth than that, but
I'm actually going to come. You went deep dive. I was going to go to surface level here just to kind of re-steer Tina just a bit. So pulse ox is measuring something attached to hemoglobin, right? Oxygen is what we're hoping for. End-tidal, if you finish out end-tidal, is end-tidal CO2. It's measuring CO2, not oxygen. So I just want to clarify that, okay? It's measuring the production and how we're breathing off CO2. Pulse ox is monitoring what is attached to that hemoglobin, which we hope is oxygen. That makes sense?
Absolutely.
Kevin, anything else you want to add on that?
I mean, moving it up a little bit at other levels, and when you start getting into the advanced level and paramedic level, more towards the advanced, is you're going to learn something called acid-base balance, and that's something that you're going to learn later on. I'm not going to teach that to you guys in this class because I'm going to lose you completely. But there are direct correlations between end-tidal, right, and pH level. Now, Zach did mention pH already. Again, I'm not going to deep dive into this. I don't want to confuse anybody. But a pH level normally for any person should be between 7.35 and 7.45. Numbers that you're probably going to see again. End-tidal is 35 to 45. It's amazing how directly how they correlate between the two. And if one is off, the other one's probably going to be off.
You put a 7. You put a 7 in front of your end-tidal numbers. That's your normal pH. So 7.35 to 7.45 is your normal pH. A 3.5 to 4.5 is your normal end-tidal. Sorry, 35 to 45. So that's a good way to remember it.
It is.
Yeah.
And another thing too is I'm not sure if maybe even Zach's heard of this or not, but there's something called the tic-tac-toe method of understanding acid-base balance, and I can teach it to a firefighter in 5 minutes.
Hey now, hey now, hey now. All right. We'll keep moving on here. Anybody have any questions from here? Because we're going to start talking about how we reposition, how we move the airway around. Any questions?
I just made my tic-tac-toe. We're not doing it?
Well, good. That's more of a deep dive. To be honest with you, I didn't learn that until critical care school. So our goal, Kevin and I's goal both, is to prepare you guys not just to be EMTs, but to further your career and give you those tools and that information. But we don't want to overwhelm you, and we want you to get the base structure before we start giving you that much information, because it can get a little out of control. So, all right.
Yeah, so the down and dirty with that though, really, like, again, we're not going to get into it. You draw a tic-tac-toe board, and our body runs alkalotic. So again, there's 3 things it measures: it's bicarb, end-tidal, and pH. I will, if you want to do that offline sometime, Tina, I will show you how to do it.
Great.
But I don't want to confuse anybody in how it works. But I teach that specific end-tidal stuff and tic-tac-toe to my advanced EMT students.
I'll learn it in February.
Kevin is the end-tidal guru, so if you have questions about end-tidal, he can give you an umbrella worth of thunderstorms of end-tidal information. So feel free to reach out to him if you want to deep dive into that. And I will tell you, if you plan on taking your career further, it's great to start learning that stuff now.
But like Zach said, we're not going to deep dive into this stuff. We need to just be easy going into it. Offline, I'll show you guys how to do a tic-tac-toe method later.
Okay, so opening the airway. There's a couple of different ways we can open the airway. We'll touch base on those. Emergency medical care begins with ensuring an open airway. Everyone heard of the ABCs? Airway, breathing, circulation. All right, so A obviously is airway. Now, in the realms of things, all of that is happening at the same time, but you need to know A, B, and C, okay? So you're going to be assessing most of this simultaneously. It's not like, oh, I'm looking at the airway. Oh, now I'm going to look at breathing. Oh, let me also assess circulation. Yes, that's how you are taught to do it, but you will be doing this all simultaneously when you're doing these skills. But let's start with airway. Rapid assessing whether an unconscious person has an open airway and breathing adequately. This is important. Airway, being able to tell what's wrong quickly is how you can save a patient's life. We're going to teach you different ways to position and why certain ways of positioning isn't appropriate for certain patients. So to open the airway, you got to know the anatomy. Again, we were talking about that tongue blocking the airway. You can see here, this is a great diagram of that. The unconscious patient, for laying flat, that tongue falls back in the back of their mouth and can block that air passage. Everyone see that? So first one we're going to talk about is the head tilt chin lift maneuver. Again, I would take note of these. These are all going to be testable questions, and they like to ask this a lot during the National Registry. This will open most of your patient's airway. Here is the key, and this is a test question. These are for patients who have not sustained or do not have suspected trauma. So this is anybody that doesn't have trauma. Does anybody know why, or want to take a guess before we go forward? Why we want to move the chin or the head?
Could have a spinal injury or a neck injury or.
Absolutely. Jennifer wins the $1 prize here. So Kevin will give you that dollar later. Tell him it's for me. All right. So again, what we're going to do, you're going to put your hand on the top of their head, your chin, and you're going to lift that back. You can probably even do that on yourself now, and you can feel that extension in your throat. It opens up that airway. It moves your head back. And again, this will tell us how this is done. With the patient's spine, you're going to position yourself at bedside or at the patient's head. You're going to place the heel of one hand on the forehead and apply backward firm pressure with the palm, which at the same time you're going to be pulling from the under lower jaw. Any questions on that? It's pretty self-explanatory with the title, head tilt, chin lift. All right, this is the next one. I see this done incorrectly a lot. So we're going to talk about it. This is the jaw thrust maneuver. This is what you would use for someone that may be injured or you suspect some type of trauma. You're going to kneel next to the patient. You're going to place your fingers behind the angles of the jaw. So everybody take a second, walk from your chin all the way back, and you'll feel a sharp turn on your jawline, right? When you talk, you can feel it move. What you're going to do is put your fingers there and you're going to push forward, and it's not very comfortable, but you can feel almost the bottom set of your teeth move forward. Everyone feel that? All right, and you can use your thumb. You're going to be actually moving it kind of like this, but you can kind of use your thumb to kind of steer their jaw. Now, if someone's unresponsive, a lot of times that jaw is going to be a lot easier. We tend to fight things just naturally out of our own protective instinct. If someone's out of it, they're a lot more malleable to move unless they're having some type of seizure or something else. All right. Even if the airway is open, the mouth might be closed. Now, this is important, and I have learned this the hard way. Opening the mouth on someone, you never stick your finger in someone's mouth. I got stitches my first year as an EMT because I thought someone was not breathing, and I stuck my fingers on the mouth and they bit me really hard. I learned that my very first year, and I've never done it again. So the cross finger technique, you're gonna put the tip of your index finger on the bottom, your thumb at the top, and basically you're gonna spread it. All right. Yes, your finger's in the mouth, but if they were to chomp down, it's gonna push your fingers away instead of pull it in. So index on the bottom, thumb up top, spread your fingers like this. All right. Any questions there? What do we not do?
Stick your fingers in.
Stick them in.
Absolutely. All right. Here's again a diagram. I did it from the front, but you can also do it from the top of their head. This is how that jaw thrust maneuver is done. It's kind of hard to demonstrate that on yourself, but you can see here, his hands reach on that angle of the jaw, the thumb sit on his front of his face, and you kind of, hate to say steer it, but you steer the jaw until it's open. All right. So suctioning, I hate to say it to you guys, but When somebody's unresponsive, there's a good chance that they're going to have some type of fluid in their mouth, be it vomit, be it blood, be it a mixture of all. It could be the Kool-Aid and beer from them partying all night long. It's just part of it. The key is that we suction that nastiness out. And the reason why, not only could it be blocking their airway, but if that were to get in their lungs, there's something called aspiration pneumonia, which is really hard to treat. And it's a pneumonia caused by foreign something down in their lungs. So we'll talk about a few ways we do suctioning. There's really two types of suction. Sorry, my dogs are being crazy. You have a portable or fixed unit. It is exactly what it sounds like. A portable suction unit is what's going to be in your bag that you take into a house or you move around with you. A fixed suction unit is going to be what's attached to the truck. Usually it's mounted on the wall or it's built into a panel in the truck, depending on what kind of ambulance they have. I think I skipped ahead here. All right. Sorry, guys. You have different types of suction devices. You have wide, thick-walled, non-keeking tubing. Usually your tip that you use in the mouth is a rigid suction tip. There's something called a Decanto suction catheter. That's my little plug. They're great. Hopefully your services have those. But basically, it's a super wide straw that you can suck large objects through versus the ones you see at the dentist that's mostly made for like liquids. Everything is sucked into a container. So it doesn't get sucked back up into the machine. It gets sucked into this container that can be disposed of properly. You're supposed to have a water supply to rinse those tips. Most of the time, almost now, all tips and everything is disposable. You need to inspect this equipment. When you have a patient with something in their mouth is not the time to find out that your stuff doesn't work. So this should be part of your daily checkoff. You should turn your suction unit on. You put your finger over to make sure it's actually pulling suction. You're a Texas unit and you want to make sure you don't get a pressure more than 300. Most of them have a dial or a valve that once it gets to that pressure, or you can set it that pressure, it'll turn off or vent away. So it won't let you pull too much. And again, this is saying just to make sure you attach the proper catheter to the tubing. All right, you're never going to suction the mouth or the nose more than 15 seconds. This is a test question, so I make sure it might not be on a Kevin test, but I've seen it on the registry. They will ask this question. No more than 15 seconds at one time for an adult patient, 10 seconds for children, and 5 seconds for an infant. Suctioning can cause hypoxia, so you want to make sure that you're not taking away from the patient's breathing because you're sucking everything in that atmosphere around it. Makes sense? So short suction just to get stuff out. Don't sit there and try to keep it in their mouth for 10 minutes trying to get everything out. When patients have that secretion, that vomitus that cannot be easily suctioned, you can roll the patient on their side. So everyone probably, hopefully we're starting to learn to get away from backboards. But if you have a patient that's strapped down to a stretcher or a backboard and they start vomiting, the absolute worst position for them to be is on their back because they can't get that out of their mouth. You can only suction so fast. The quickest and easiest thing to do is just to roll the patient over and let it kind of gravity be your friend. It says here to clear the mouth carefully with a gloved finger. Again, I don't stick my finger in anybody's mouth. Use that suction catheter. Use whatever you can to help kind of scoop that stuff out. But, you know, I would be very hesitant to tell you all to stick a finger in anybody's mouth. And I'm sure Kevin would agree on that one. If the patient is producing a frothy secretion as quickly as you can suction it, you want to suction the airway for 15 seconds if it's an adult. Ventilate for 2 minutes and continue that pattern. So frothy secretions usually means it's coming from the lungs. It's basically you're blowing bubbles through your lungs. So this could be from a drowning. It could be something from what we call pulmonary edema or flash pulmonary, where the lungs are filling up with fluid. And as they exhale, that fluid is being moved up. These patients are in rough shape. The idea is you need to try to get as much of that out of their airway, but also make sure you're ventilating them. And again, you're going to alternate a pattern trying to clear that airway. Prevent obstruction by the tongue and allow passage. So again, this is talking about that tongue. There's a device called an oral pharynx airway device, or an OPA. You might hear hear it be called an OPA. That's kind of the short-term name for that. This is a device that kind of helps pull the tongue forward to allow easier ventilations. The problem is if they have a gag reflex, you're not going to be able to put that device in. And we'll talk about a few of those air-to-way devices here in a bit. But it does make it easier to suction and to get ventilation. And here we go, talking about those OPAs. It's going to be an unresponsive patient without a gag reflex. You can use it for apneic patients. So anybody know what apneic means? Anybody remember? Someone tell me what apneic means.
Periods of not breathing.
Perfect. Apneic is not breathing, or not breathing would be the best way to describe it. Not breathing. People who we don't use OPAs or oropharyngeal airways are conscious patients and any patient with an intact gag reflex. Pretty common sense there, right? We're not going to put something in somebody's throat if they can gag. It just won't. You're going to cause more vomit probably. Nasal pharyngeal airways. So these you might hear them called MPAs, nasal trumpets, nose tubes. There's a lot of different names for them. They look like a rubber tube with a flare on them. And this is something they're going to put through the nose. It goes into that nasal pharynx. And if you're using a bag or even if the patient is having trouble breathing, it'll help open up that airway. We're going to use those in patients. Hold on just a second. We're going to use those in patients that are unresponsive or have an altered level of consciousness that do have that intact gag reflex and is unable to maintain their own airway. So if they're having trouble maintaining their airway, they're altered or unresponsive, but they still have that gag reflex, MPA is always the way to go. There are some exceptions to that, and we'll touch on this in just a second. Nasal pharynx indications, again, semi-conscious, unconscious patients with an intact gag reflex, patients who are not tolerating OPA. So some people say, well, how do you know if they got a gag reflex? Well, you try an OPA and they gag, well, there's your answer. Now go to an MPA. The contraindications, and this, again, another test question that you will see, severe head injuries with blood from the nose or history of a fractured nasal bone. Anybody know why? They got a fracture in their nasal cavity and we put something through their nose. Where does it have a potential to possibly go?
Your brain.
Yeah, it's not as long as some of the other things that we can do nasally, but it can end up in the wrong cavity. You can get in the sinuses, you can get in the cranial cavity, and then you start putting air in those. Air in places that they don't belong is painful and can cause a lot of other problems. Everybody tracking on that one. When can we not use an MPA? Anybody? I change it off the screen. Somebody give me an answer, please. When can we not use one?
Nasal fracture
All right.
and
All right.
blood coming out of the nose.
Perfect. All right. Maintaining the airway. Like we talked about earlier, if we're suctioning the patient and we need to roll them on their side to get that vomit out. This is what we consider the recovery position. Now, what makes it the recovery position here is we have the arm supporting the head and the knee raised, which causes kind of like a tripod. It keeps them from rolling over on their stomach or their back. I guess this has been added to the recovery position has been added to the curriculum, but most of the time you'll see this in like a basic first aid or lifeguarding class. 99% of the time, we're going to be rolling on their side. We're going to be suctioning. There's not a whole lot of times where we'll be placing positions or patients in recovery position, unless Kevin wants to jump in. I can't think of a time where that's used very often. You with me, Kevin?
I'm just
Okay.
trying to log in on the computer, so give me a few minutes.
You're good.
What was the question you had? Sorry.
Just talking about recovery position, how, yes, they need to know it, but it's not something that we'll be utilizing too often because we'll be transporting, suctioning, or rolling them on their side.
So in airway management, recovery position is going to be important, or left lateral recumbent will be important when we start talking about obstetrics. But other than that, getting the patient off the, my God, I can't think of what it's called. Supine hypotensive syndrome.
Gotcha.
The vena cava. Vena cava. Sorry, I had to think about it for a minute. So,
All right. We are getting ready to get into oxygen. Why don't you guys take about a 5-minute break? Breathe in some of that fresh oxygen and take a little break, okay? I'm probably going to jump off here soon. It's been a pleasure talking to you guys tonight. You'll all see more of me here soon, but it's good to be able to have a talk. Again, if you all have questions, if you want to talk to somebody, my email is always open. My cell phone's always here. Feel free to reach out.
Thank you.
Thank you, Zach.
so
Absolutely.
before you log off, Zach, I want to make sure you can transfer it to me when you can leave so the recording stays going. But I have to get in the system first, so hold on. Where were you on the presentation?
I'm on slide 71.
Okay. All right. There's a way for me to take it over, and I'm trying to remember how to do it. On right here, I think it's take control. But I'll just log in with mine. So let me just bring up this really quick here.
Okay, you're good.
All set.
What was that? I'm sorry.
So I'm just trying to bring up chapter 11 so I can bring it up in my presentation for my
right.
365 on my side. And then hopefully we don't lose the recording. I'm downloading the PowerPoint now.
All right.
Well, thank you for the help tonight.
Yeah, man. Anytime. Apologize, I can't stay longer.
Oh, you will eventually. Once
Oh, I
get
know.
settled in.
I gotta get through this week. I actually have the other computer right here tracking trucks because I'm at status 0. I'm at status like -4 right now. I've got 9 pending runs.
Wow.
Hey, Kevin, this is Jason Sear.
Hey, Jason.
Hey, yeah, I was gonna not make it tonight, but I'm here at 7. I did put a request in, but I'll watch I took all day tomorrow off, so I will
Okay.
watch the first hour tomorrow. So
Yeah, no worries. We'll get there.
I was talking with somebody that took your class last year, and I was telling her I was a little frustrated at the beginning, and she's like, it'll click. And I got the book in the mail yesterday, and I was reading it last night, and it started to click. So I think she was right. I hope she's right. Anyways, but
Who was it?
my old Nancy Priest from Oxford.
Oh,
area.
Nancy. Yeah. She took my
She
EMT
works-
class a couple years ago.
Yeah, she worked. Oh, maybe it was a couple years ago. She works with my wife in Oxford. So
Oh, nice.
yeah, but
Yeah,
no,
she took a bunch of classes with me so far.
she did. Yeah, she's big on Oxford Fire right now. So, but I my old brain needed the book. I think the book is going to help me out a lot more. I can highlight and write in the note, right in the medians and stuff. So it'll help me out a little bit. But
And
cool.
Jason,
Yeah,
I'll tell you, and I kind of felt the same way when I started EMT, is you get all of these puzzle pieces, right?
Yeah.
And eventually it comes together to make one
Yeah.
picture. You
Yeah.
just gotta bear with it
Yeah.
till it starts to take kind of
Yeah.
take effect. But I promise you it starts clicking. I was the same way. I was like, what did I get myself into? Like,
I know. Trying to work a full-time
I
job.
promise it starts to make sense, and you start to say, oh, well, that does that. So that makes sense why this is doing that. So it'll come, I promise.
The book's helping me because I keep the chapter open for medical terminology. And then as I'm reading, I'm like, what does that mean? I'll flip it back and I'll get it. So then every time I see a word, I'm like, that means this in my head, So yeah, it's I'll get there.
So, Zach, when you decide you're going to log off, don't end the meeting for all. Just leave the meeting on your own.
All right. Will it keep recording, or you just want me to leave my computer up and record?
It should keep. You can leave it open if you want to. It's up to you. I just took control of the meeting, but I'm not sure if it will stop recording if you log off or not. So
I'll just leave it up. I'll come back towards the end and kill the recording.
all right.
All right, buddy. Thank you, guys. Have a good night.
Thanks, Zach. All right. Trying to see who else is on right now. Everybody back?
Yeah,
Yeah,
I'm back.
This Jason, I'm
here.
back.
All right. Morgan, you back or you want to call? You might be on a call with it open. All right. I just gotta find my screen here. Well, that didn't work. Well, let's do that instead. All right, I can write again. All right, give me like 2 minutes and we'll get the class started back up again. We'll be good to go. All right, is everybody back?
Yep, Jason's here.
All right. So we will get started and we'll finish up here. We're about halfway through the presentation, so it's probably not being an early night, which will be good for some people since we've been going till 10 o'clock last couple of classes. So supplemental oxygen. A lot of things to understand about it, a lot of things to know about it. How many liters per minute we're going to be giving, how we're going to be administering it, to the actual percentage of oxygen actually being administered through the device that we're administering. So always give supplemental oxygen to a patient who are hypoxic because not enough oxygen is being supplied to the tissues and the cells of the body. So there are a couple ways that we can figure this out. One, we can look at pulse oximetry. Keep in mind that is just a tool. It does not replace the knowledge and experience that you have along with the assessment skills. But if a patient is short of breath, never withhold the oxygen. Just be cautious on how much oxygen that you are giving to the patient. Some tissues and organs, such as the heart, central nervous system, the lungs, the kidneys, the liver, they all need constant supply of oxygen to function normally, right? There are 3 things the body has to have in order to stay alive, right? What are those 3? What do you guys think they are?
Oxygen.
Okay, yeah. So O2.
Water.
What else? So I'll give you that. Do blood, water, and the last thing.
Nutrients?
Fuel, nutrients, yeah.
Yeah. Sugar. If you take one of those away, the body dies. Now, who's a firefighter in the room again? We have a firefighter, right? Yeah. So, Jason, if you have the fire triangle and you remove fuel, heat, or oxygen, what happens?
Fire goes out, hopefully.
Fire goes out. Remove blood, oxygen, or sugar, the body's dead. Right? Good way to remember it. It's like the human triangle. Right? So we got to think about that. The body has to have these three things. So never withhold oxygen from a patient who might benefit from it. Key word, benefit. Right? And if you must, assist ventilations. So if they're breathing too fast, tachypnea, too fast, or they're breathing too slow, so Brady, right? We need to assist that ventilation status because they're not going to perfuse appropriately, right? If they're breathing too fast, carbon dioxide goes down. If they're breathing too slow, carbon dioxide goes up. So supplemental oxygen equipment, we have oxygen cylinders and there's different sizes. They have H tanks, K tanks, M tanks, D tanks, and they're all just different size, but they hold pretty much the same amount of PSI, it's just a larger volume, right? So the oxygen that you will give to patients is usually supplied in a compressed gas, and is a compressed gas in a green steel or aluminum cylinder, right? So check the cylinder and make sure it's labeled for medical oxygen. You don't want to give them the wrong stuff. There are two different types of things that sometimes can be found in ambulances, more towards the critical care side, but they have medical air and oxygen. Medical air is usually in a yellow tank, green tanks, or the aluminum steel to the top, whereas green ring is the oxygen, or they're fully green. So check the month and year stamps indicating the cylinder was last tested. They do hydrostatic testing on all bottles like that. Aluminum cylinders are tested every 5 years, and composite cylinders are tested every 3. The most often, the D or the jumbo D cylinder is what we have. As far as a portable tank goes, is a D tank. You might see that again on a quiz, right? The length of time that you can use an oxygen cylinder depends on the pressure in the cylinder and the flow rate. So if you give somebody 15 liters a minute, you're going to deplete that oxygen faster versus someone you're going to give 4 liters a minute to. Liquid oxygen is now becoming more commonly used as an alternative to compressed gas oxygen. As far as liquid O2 goes, right here, all right, we're not seeing a lot of that pre-hospitally, but you'll see that outside the hospital supplying the hospitals with oxygen. They use liquid oxygen that way instead. Right? We're not really seeing a ton of that in EMS yet. Not saying it's not coming. Safety considerations, handle the gas cylinder carefully because remember, their contents are under pressure. A lot of pressure. 2,000 PSI and higher. So make sure that the correct pressure regulator is firmly attached before transporting cylinders. We're going to go over all that stuff on hands-on day. A puncture a hole in the tank can turn it into a deadly missile, and it will fire, and these things can actually blow through concrete walls. Cylinders with the mounting brackets, when they are stored in the ambulance, so they have to be secured. Nothing can be free floating, rolling around. So they need to either be in an oxygen bag or secured in a cylinder holder or some type of bracket. Oxygen cylinders that are in use during transport should be positioned correctly and secured. Right. So a lot of times now what we're seeing D-tank mounts either at the foot of the stretcher or at the head of the stretcher, or on the kind of like the elevation where the head would go. It depends on where the mount may be on the stretcher itself. But don't ever let anything sit free floating. So the pin indexing system is each portable cylinder of a specific gas type has a given pattern and is given a number of pins following accepted national standards. The pin indexing system prevents the oxygen regulator from being accidentally connected to an incorrect gas cylinder. So you'll notice that they have two pinholes where the oxygen regulator goes onto. Now, a lot of services are getting away from those and going to a built-in regulator now. So we're starting to see those changes and differences. For large cylinders, the safety system is the American standard safety system that uses that. Oxygen cylinders are now equipped with threaded gas outlet valves. And inside and outside thread sizes vary depending on the gas cylinder, preventing any kind of accidental attachment or regulator to the wrong cylinder. So I cannot take a medical air valve and screw that on to a cylinder on oxygen because the thread is different. It will not allow me to do it. Or that you can't really screw it up. Pressure regulators reduce the cylinder's pressure to a useful therapeutic range for the patient, usually about 40 to 70 psi, right? So if you had it wide open and you didn't have a regulator, like a high pressure regulator, bringing it to low pressure, then you'd have a significant amount of pressure, 50 to 100 psi, coming out of patient, and it would actually destroy your lines. So there is a regulator that converts it over from high to low pressure. A quick connect female fitting that will also accept a quick connect male plug from a pressure hose or ventilator resuscitator. We see those more on vents. All the trucks that I work on in New Hampshire have those now. I put those on those trucks. So that way, if you're using a ventilator, we can do a quick connection. Now, the ambulances itself have a quick connect that goes to the regulator that brings it to 1 to 15 or 25 liters per minute. Again, a lot of talk about this. You guys actually need to see it. So you'll have that opportunity on Sunday to look at the Berlin ambulances. The one will end up coming over, and you guys will take a tour of the ambulance as well and kind of see what these connections look like and what the back of the ambulance actually is. A flow meter, which is what directs the flow. That can either be a turn dial to a specific number or be like a floating ball inside of a chamber. A flow meter that will permit a regulated release of a gas measured in liters per minute. Understand what LPMs are, okay? That's different than percentage of gas. And you guys are gonna have to know the differences between a non-rebreather, nasal cannula, and a BVM, and what flow rate, liters per minute, and percentage of oxygen being administered based on those flows. Flow meters are usually permanently attached to a pressure regulator on an emergency medical equipment. A pressure compensated flow meter incorporates a float ball, right, with a tapered calibrated tube. It is affected by gravity and must always be upright. So you guys will see those too. The Bourbon gauge flow meters is a gauge calibrated to record flow rate and can be used in any position. So again, you'll be able to see those differences. Procedures for operating and administering oxygen. So the first thing you want to do is you're going to crack your cylinder open. Do you guys have your skill sheets in front of you at all? If you have them, you look at the airway management, all right, assembling an oxygen bottle is on there. And the first thing you want to do is you want to crack the tank while it's still open or while the regulator being on it to make sure you're free of any debris. You want to then take the regulator and put it over the top onto the openings and make sure that there's a gasket in there so it doesn't leak. Then we attach the regulator to the tank itself. That way there we can turn it open up all the way, no leaks. We can go to there. Our next step would be is selecting our liters per minute flow. There is a skill drill 11-7 in your ebooks or in the books if you purchase the textbook itself. And then hazards of obviously supplemental oxygen as well. It really doesn't, if there was a leak inside the ambulance, a slow leak, it wouldn't really hurt you. But if there was a massive leak and you were stuck inside, it's a natural way to kind of get high with that. But again, you don't want to over oxygenate our systems. There used to be something called oxygen bars back in the day. Maine had a couple of them where you could go and basically sniff scented oxygen and pay for it. So combustion, oxygen does not burn or explode. Remember that. It assists the combustion process. Oxygen it enhances burning. It doesn't actually explode. Does that make sense, everybody? So keep any possible source of fire away from that area while oxygen is in use. You also want to make sure that the area is adequately ventilated as well, especially in industrial settings. Never leave oxygen cylinders standing unattended. If they can fall over, they can break off the regulators or the tops of the bottles, causing a significant incident. You'll go to, I guarantee you, at one point in time in your career, at least once, if not more, you'll go to a residence where someone was smoking a cigarette with a nasal cannula, which enhanced the burning and caused basically like their entire face on fire. Right? There's somebody in a town that I work in who we've been there like 2 or 3 times for that same incident. Same person burned their face 3 times. They didn't learn the first time it actually happened. Right? So it's actually out there. Oxygen toxicity is a thing. You can give somebody too much oxygen. Our ranges that we look for are between 94 and 99%. We never actually want to hit 100. Not all patients require high flow, right? High flow oxygen for long term can do a lot of damage and increases our partial pressure of oxygen within the system, right? I know that you heard Zach talking about partial pressures, right? PaO2 will be increased, right? And you may, and then what they'll do is they'll do a blood gas in the hospital and find that it's like 400, which is way higher than it needs to be, right? Because EMS always puts on a non-rebreather because that's the way we taught you in school. Everybody gets a non-rebreather 15 liters a minute. Well, not anymore. Now we need to be clinicians. What do they need, right? Again, not all patients require high flow. Maybe a nasal cannula at 2 liters, 3 liters is all they need, just enough to bring up their oxygen saturations and help them oxygenate, right? Excessive supplemental oxygen can have a detrimental effect on all of patients with certain illnesses like COPD, right? Cerebral vascular accidents, strokes, MIs, right? They do need oxygen, but not a high flow amount, right? Now, if you have a COPD patient who's sitting in the 60s, absolutely high flow oxygen, non-rebreather, let it run. But put them on end tidal, look at their readings, look at the measurements, and when things start to normalize and you start meeting that homeostasis, the mask comes off and put them on the nasal cannula. All right. Oxygen toxicity refers to damage to the cellular tissue due to excessive oxygen levels in the blood. It will actually start causing damage. So increased cellular oxygen levels contribute to the production of oxygen and free radicals, which can lead to tissue damage and cellular death in some points, right? So we want to make sure that we're not over oxygenating the patient, causing significant free radicals, right? The International Liaison Committee of Resuscitation Guidelines, published by the American Heart Association, recognize that there may be a negative effects on oxygen toxicity and recommend that the oxygen may be administered to patients experiencing signs of myocardial infarction when they have signs of heart failure, right? Are short of breath or have a room air oxygen saturation of less than 94%. Memorize that number, less than 94, right? Now, COPDers retain carbon dioxide. Therefore, in turn, will have an SpO2 level around 90%. That is normal for them. It is okay to be at 90 because that's what they live at, right? We don't, even for short term, we don't want to just increase that oxygen level to 99 to 100%.
Kevin, is COPD the type of something that they would put on a medical alert bracelet, a medical bracelet?
Maybe sometimes they can, but there's other things you can look for as well. So there are indicators. So one of the things you'll see with a COPD are more like emphysema. Again, we'll cover more of this in respiratory emergencies. It's something called increased AP diameter, or what they call the barrel chest. Right? So they could have a barrel chest. So that's when the chest wall is expanded out. You see that barrel-looking chest. Those are indicators of patients you might find with COPD as well. But again, they could wear a medical alert, but look at their medical history as well. Not medical history, medications. Are they on any kind of bronchodilators like albuterol, Combivent, things like that they take at home? Are they on home nebulizers? All right. You can also tell by the way they breathe that they're doing a lot of pursed breathing from moving. So there's other questions you can ask as well, but they're different from asthmatics. That answer your question?
Yes.
Okay. Awesome. So patients experiencing signs of shock should be placed on oxygen, because we can look at that pale, cool, clammy diaphoretic skin. We can see tachypnea with normal blood pressure. We'll see tachypnea with tachycardia. So tachypnea, remember, is rapid respiration. Tachycardia, heart rate of greater than 100. The reason why that's happening in shock is because now our cells are not perfusing appropriately, so inadequate state of tissue perfusion, right? So the body's mechanism is to make you breathe faster, in turn brings in more oxygen. Heart rate goes up to transport those red blood cells, hemoglobin, with attached oxygen to the cells that need it, right? So we got to fix that. And by giving a patient oxygen who's in shock will help with that process, and in turn should bring, unless it's a hypovolemic issue, should start bringing your heart rate down and your respiratory drive back down to normal. But if there's hypovolemia and they've lost fluids and everything else, then they need to have fluid replenishment and replacement. All right. So oxygen delivery equipment in general, oxygen delivery equipment is used in the field, should be limited to non-breathing masks, BVMs, and nasal cannulas. We used to have simple masks, Venturi masks, and all that. They said, you know what? That's way too many different devices that are out there. Let's keep it simple. There is one other mask, though, that you guys have at your disposal in Maine and in New Hampshire. And also Massachusetts just started it, and that would be CPAP, right? So we will cover a whole entire different section of CPAP and respiratory, and you guys will be certified in how to use CPAP for Maine and New Hampshire, all right? We'll go over the protocols for that later. Non-rebreathing masks. Combine a mask and a reservoir bag, as you can see here. This, where I'm circling here, that is your reservoir bag. This is the mask on top, and this coming out like here, that's your tubing that would hook into a regulator on an ambulance. A little knob here, and that little Christmas tree, it's called the Christmas tree, it's green, on the bottom. As we turn the oxygen on, you want to make sure you take your finger and put over the little flap inside here, along the reservoir bag to fill. Do not overfill it, as it will pop. Okay, so don't overfill it. Once it's on, take this right here, put it over the patient's face. There's a little metal bridge up here, but it's a little bit lower down here, right? Pitch that on the nose and put the green strap around the back of the head and pull on your straps. And that secures a non-rebreather, all right? A non-rebreather flow rate, all right, can be done from 10 to 15 liters per minute. All right, you might want to write that part down. That's very important to know, 10 to 15 liters per minute. But on top of that, what I want you guys also to know is that it delivers between 80 and 90% oxygen. Okay, so up to 90% oxygen it can deliver. All right. Okay. Now, the nasal cannula has two little prongs here, and they kind of curve like this and like this. So the oxygen, if it was a nasal cannula coming across like this here, and then your tubing kind of wraps around the neck this way, like that, and then double tubing goes into the regulator. These curvatures have to curve in the way of the nasal cavity goes. Okay, so if you put them on backwards, it goes up into the tissue and the cartilage, and it blocks off the oxygen flow. So make sure you're following the curvature of the nose. It goes around the ears and back around to the neck, where then it ties off, and then, like I said, the tubing comes off and goes right to the regulator. Flow rate 1 to 6. Percentage 24 to 44%. All right. 1 to 6 liters, 24 to 44. So you see the difference already? if I have someone who just needs a little bit of oxygen and I put them on a non-rebreather, they're going to get 90% oxygen. That's a lot. Do they really need that much? No. That's dumping a lot of oxygen to the patient that does not need it, right? So let's look at the lower numbers. I can set someone a nasal cannula at, let's say, okay, 4 liters per minute, and that'll deliver right around 30% oxygen. That might be all I need. Even patients that I put on ventilators that are intubated, right? If they're oxygenating and perfusing normally, I may only have at 30 to 40% FiO2, which is fraction of inspired oxygen, right? So I'm looking at that number, 24 to 44. Patients that are intubated who are sick patients that might not need high oxygenation because it will kill them. Oxygen toxicity, all right? And if I'm sorry to scare you guys a little bit, then that's my plan, is to make sure you guys understand that oxygen really can kill somebody if given too much long term. So short term stuff, look at what the patient needs, right? If they're cyanotic and their SpO2 is at 60% and they're pale, non-rebreather. If it's a chest pain with a little shortness of breath, their oxygen is right around 92%, nasal cannula at 4 liters, right? That's all you have to worry about. And in turn, use the end tidal too. So nasal cannulas are used in patients with mild hypoxemia, right? So what would this mean? What is hypoxemia?
Low.
I don't know. I've lost
amount of
Kevin. I
oxygen.
can't hear him.
What was that? Can you hear me okay still?
Yeah.
Jen, was that you that
It's-
said you couldn't hear me? All right. So what is hypoxemia?
A low amount of oxygen being delivered.
So I'm going to split it right here down the middle. Okay.
Kevin, I can't
So-
hear you at all.
Everybody else can hear me fine though? Yeah. Yeah. All right. Jen, you may have to log out and log back in again.
Okay.
You're having a hard time. Everybody else can hear me fine. So.
Okay.
All right. So hypox being low oxygen, right? Emia is blood. So low oxygen in the bloodstream, right? If I said hypoxia, shortness of breath, right? Hypoxemia is lack of oxygen in the blood. So anything that has the word emia after it has to do with blood, like uremia, right? So, or bacteremia, bacteria in the bloodstream. And we'll talk more about that. We talk about shock and septic shock with bacteremia, right? So kind of have an idea of breaking those down with medical terminology. So a patient who breathes through the mouth or has a nasal obstruction will not benefit from a nasal cannula, all right? So you have to take a deep breath in through the nose, out through the mouth. When you anticipate a long transport time, you can consider using humidification or humidified O2. Not many places actually carry humidified O2, but they do have the little containers hook onto the oxygen regulators itself on the truck, and they just kind of bubble oxygen or humidified oxygen into it. Heated humidified oxygen works really well for your hypothermic patients, but again, not many services carry those, if any at all, anymore. So partial rebreathing masks. Again, we don't do a lot of partial rebreathing masks anymore. We don't really exist on trucks. We really don't carry them. But again, we'll talk about them here in case you ever get tested on it. Similar to a non-rebreathing mask, except there is no one-way valve between the mask and the reservoir. It's just a complete mask. Patients rebreathe a small amount of their exhaled air. So they're rebreathing their carbon dioxide that they're exhaling. This is called a Venturi mask. So it has a number of attachments that vary from percentage of oxygen with a constant flow that is maintained from the regulator itself. So it's a medium flow device and delivers 24 to 40%. All right. I don't do a lot with this stuff here. We don't even carry them on the ambulance at all. We carry non-rebreather, nasal cannula, and a BVM or CPAP or BiPAP for the medic level. This is called a tracheostomy bag. My goodness, a tracheostomy mask. These are patients that have tracheostomies. So if they have a port in their throat, so if their airway is here, there's an opening here, and there's what looks like an intubation tube almost, but it kind of sits down inside and goes into through the trachea and kind of delivers air that way. So again, one common thing with tracheostomy tubes is what they call mucus plugs. They have a lot of mucus inside. We might need to suction out the area for that, right? But as an EMT, we do not do deep suctioning. That's a medic skill where you get to go deep into the lungs to pull out more mucus and phlegm and things like that. But they have specialized masks that go over these trach tubes. So a tracheostomy mask cover the tracheostomy hole and have a strap that goes around the neck, right? Now, some people may not have anything at all, and it'll just be the hole itself. I will give you fair warning, right? That if they have congestion and they cough, all right, it's like a geyser of phlegm coming all over your face. All right. So I want to keep that in mind. If you're dealing with tracheostomy stuff, make sure you're wearing a face mask and goggles because it may end up spraying all over you. All right. That's some real world stuff I want to talk to you about. All right. These may not be available in the emergency setting as far as these masks. A lot of services do carry them now, though. In some cases, you improvise by placing a face mask over the stoma, which is the opening of the hole that's there. What really works also is a non-rebreather mask. You just put it over the top of the stoma, and usually that works perfectly fine. Assisted and artificial ventilation. This is your bag valve mask. Basic airway ventilation techniques are extremely effective when administered properly, having a good seal. And one of the seals we talk about is called an EC method, right? So if you take your hands, your hand, open it up in front of you, make a C with your thumb and your index finger, your pointer finger, right? And then turn it sideways, and you can kind of see the C, and then you have your middle ring and pinky, looks like an E, okay? So the C goes around the mask and holds it down to the face. The E goes underneath the jaw and pulls the jaw up and displaces it, holding your head till chin lift. So you get an accurate seal and a good airway, all right? So that's what they call the EC clamp or EC method. We use BVMs for inadequate ventilation. So again, altered mental status, rapid respirations or decreased respirations. So anything above your 24, 26, 30 breaths a minute. You can be breathing 26 times a minute and not need a BVM. Again, I tell you these numbers, look at your patient before you do it, right? Or if they're breathing like 4 times a minute, maybe because they're in respiratory failure, almost in the respiratory arrest, or they could be in a narcotic overdose, opiate. Inadequate minute volume or excessive accessory muscle use and fatigue. Patients that are COPDers or asthmatics that breathe for so long eventually get tired. When they start getting tired of breathing, they start going into failure. Eventually, the smooth muscles will no longer be able to function appropriately, and they'll go into respiratory arrests. Right? So that's what we kind of want to watch for. Prevent it from getting the failure. Help them breathe. Breathe for them. To assist the patient with ventilation is using a bag valve mask device. Explain the procedure to the patient. I'm going to put this mask over your face, and I'm going to breathe every single time you take a breath in to help control that. These are for your tachypnic patients, right? But again, why are they tachypnic? Right? So those are things you got to look for. Right? If they're unconscious, there's no explanation. Just keep breathing until they wake up. Squeeze the bag each time the patient breathes, maintaining the same rate as the patient. So you could be breathing 40 times a minute, but that hypoxic drive is going to change, right? It's going to change for the better, and hopefully, in turn, bring that rate down. And that's the goal behind it. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume, right? If you're looking for numbers, tidal volume is right around 5 to 600 mLs, okay? We don't look at numbers anymore. We look for chest rise, okay? Good tidal volume means good chest rise. If you overventilate a patient, what do you think would happen? Remember, I said ventilate, not oxygenate.
Can it go into the abdomen?
Right, via the esophagus, right?
Yeah.
What else could happen when you overventilate somebody?
Don't you throw off like the whole pH system?
Eventually you could do some stuff like that, but think more of trauma.
Can you damage the
Hypoxia?
lungs?
Sorry, two people at once. What was that?
Can you damage the lungs?
You can. Overventilation can damage lungs, especially if you overinflate. Maybe not so much with an adult, but imagine using an adult BVM on an infant,
Mhm.
right? That's what we call barotrauma. Okay. Barotrauma can cause a tension pneumothorax or a pneumothorax going into tension, right? That's your collapsed lung, right? You can cause a lot of damage by overventilating somebody, right? Now, our BVMs, back valve mask, I'm going to use BVM from here on out, right? Delivers 100% oxygen because there is no leak. It's a direct valve, direct one way to right to your airway using a mask, a BVM, and the BVM has an oxygen reservoir. So you'll have a mask that goes like this around the face. You'll have a 90-degree angle tubing that's hard plastic that goes here. Then you'll have a bag like this. Sometimes they have a little handle on it, right? And then you'll have a valve here. And there's a one-way valve in here as well, so vomit doesn't come back up inside of it. And there's a bag that comes off the back of it, like this. That's your reservoir. I put in a little R here, right? And down here, you'll have a piece of tubing that hooks into your oxygen regulator over here, okay? You want this to fill up. So I'll do a 1 here. That needs to fill.
I think he lagged out.
Yeah. Did anyone else get kicked out before?
My internet went down a couple minutes ago, but I came back. But I think
I don't
Martin
think it was
fell.
your internet because I got lost and all that too.
Uh-oh. And Zach and Morgan not here anymore.
I don't think so.
I'm here.
Oh, Morgan, I think Kevin lost connection.
I see that. Which slide was he on? Does anybody know?
Slide
Ooh.
92.
Yeah.
92. See if I can do this.
Oh, my fault. My computer died. I thought I had plugged it in. I just
Oh,
went right
there it
away
is.
and started teaching. So my apologies. At least it kept recording. So enjoy your 30-second break. All right. So now that we're back here, I got to bring my presentation back up again. Wherever that may be. All right. So back to the BVM. So what happens is here, I'm not sure where we left off. We talked about filling the reservoir up with oxygen first.
You were talking about how much, yeah, and then how much percentages the BVM can administer.
Okay, so 90%, so 100% oxygen, right? and we deliver, we set this here to 15 LPM, right, at the regulator. Oxygen comes in, reservoir fills up, in turn will then also fill here on this side on your bag. When you squeeze, the O2 from here then gets delivered into the airway. As you release, the oxygen from the reservoir bag pulls back into the squeeze bag here, so to be able to give your next breath. As that's happening, the oxygen is now filling up the reservoir bag and going in. Oh, you can't see the slides?
So I don't see your slides all of a sudden.
Yeah, hold on.
I thought it was me again.
No, it's probably me. That's better. There you go.
Yeah.
Did I do something up?
Much better.
Perfect.
What was that?
I was just asking if I screwed something up.
No, it wasn't you. My computer actually died on me.
I got you. Okay.
So thank God it kept recording. No, there was no screw up at all. That was my end. All right, you can see my screen now.
Yes.
All right, cool. Right. So now you see all these numbers and drawings that make no sense to you. So oxygen comes in, fills the reservoir bag, fills the bag here initially here, your squeeze bag here. As you squeeze in, oxygen goes out into the airway. All right, as you release the bag, the oxygen that's over here then goes from reservoir to squeeze bag, and then your, excuse me, your regulator then continues to fill the reservoir bag, and it just keeps going in a system. If this is empty, then each breath, every other breath is not getting oxygen, okay? So you got to make sure you squeeze and breathe normal. What we don't want is a hyperventilate. Hyperventilation does something very, very bad for us, right? The lungs can only take so much air, and if you overventilate, it bypasses and goes down the esophagus. If it goes down the esophagus, we start getting gastric distension, right? So if we have a body with a big belly going into the body here, and here's the head. I'm horrible at drawing, by the way. What's happening is that the belly is so full of air, it starts pushing in on the diaphragm like this. So if you're having someone in cardiac arrest, we're not going to be able to effectively oxygenate the heart because we're pushing so much pressure from that diaphragm from the stomach being so overinflated, right? This is why for paramedics that are on this call right now too, anytime you intubate somebody, always drop an OG tube, right? An oral gastric tube to deflate that stomach, right? You have to deflate that stomach in order to relieve the pressure in the thoracic cavity, right? So now this goes back to BLS, a little BLS topic as well, is don't overventilate. Overventilation causes this, right? This is bad. We don't want that, right? We want to keep it normal, right? So one breath every 8 to 10 seconds, normal breathing. You don't have to hyperventilate somebody, right? Unless the paramedic tells you to do so, right? And that's a whole different world, different game. We'll talk about that another day. All right. So normal ventilation versus positive pressure ventilation, all right? Artificial ventilations are necessary to sustain life, but they are not the same as normal breathing. And normal breathing, another word for normal breathing is called eupneic breathing. Right. So the diaphragm then contracts and negative pressure is generated in the chest cavity, which sucks air back into the chest. If everybody takes a deep breath in and out, right? So that's how our diaphragm is working, which Zach covered earlier. Positive pressure ventilation generated by a device forces air into that chest cavity, which is a good thing if a patient's in respiratory arrest and they're no longer breathing. And we can force that air into the cavity, allowing for good chest rise and fall, good chest expansion. In turn, we're also oxygenating. Now, if there's no pulse, we need to assist that heart by giving CPR. If there is a pulse and the pulse is fine and they're in respiratory arrest only, all we have to do is breathe for them. That's it. All right. And we have other devices now, especially at the EMT level, called King Airways. or we have supraglottic airways that we can utilize to secure airways in place. So we'll talk more about that later in the practical sessions. So with positive pressure ventilation, increased intrathoracic pressure causes compression of the vena cava and reduces blood return to the heart, which reduces the amount of blood pumped by the heart. So more volume is required to have the same effect as normal breathing, which pushes the air walls out of their normal anatomic shape, right? So air is forced into the stomach, causing gastric distension that could result in vomiting or aspiration, right? So again, more air in the stomach, more chance something's going to have to give somewhere, and it's going to be vomit coming back out, right? And now we've occluded that airway, and we have to go back into suctioning, right? And if they aspirate it in, now we're taking an acid and we're shoving it right down their airway, right, into the bronchioles, into the alveoli, causing a nasty lung infection, right, which is something that we don't want. Right. So the EMT must regulate the rate and volume of artificial ventilations to help prevent the drop of cardiac output. Right. More ventilation, reduce cardiac output. We don't want that. Okay. Ventilation rates for apneic patients with a pulse. So not breathing with a pulse. For an adult, it's 1 breath every 6 seconds. You did 8 to 10, it wouldn't hurt them at all. Real world. For the testing scenario, 1 breath every 6. For a child and an infant is 1 breath every 2 to 3 seconds. Right? When we start talking about infant CPR, right, we'll look at the 30 to 2, 15 to 2 ratios. Right? Neonates are a different world, and it's something that you will be dealing with if you deliver a baby. And our compression ratio for the airway management for breathing is 3 to 1. 3 compressions, 1 breath. 3 compressions, 1 breath. That's our breathing ratio. Right? But that's neonate. And neonate is newborn to 30 days old. Once they go past the 30-day mark, they become an infant. All right. We'll cover all that later in pediatrics. Mouth-to-mouth or mouth-to-mask ventilation. Well, I'm never going to do mouth-to-mouth to anybody. Right? It's not happening. Mouth-to-mask, absolutely, because they have a one-way valve. So if someone vomits, it doesn't come back up into your mouth. Right? You need to have that one-way valve. A mask with oxygen inlet provides oxygen during mouth-to-mask ventilation. Right? So here's our BVM. Here's our bag. Right? Squeeze ball, mask. This mask here has air inside of it for a seal. Some of them can deflate, and there's a little inlet valve down here where you can put like a 10 ml syringe on it and you can fill it back in with air again if it deflates, especially if it's been sitting for so long in your cabinet it's not being used. But normally they're perfectly fine. In New Hampshire, you are required to have a PEEP valve on every BVM. It's a requirement for the state of New Hampshire. Right? You have a PEEP valve. All right. 100% O2, that's your percentage. Your flow rate, 15 liters per minute. All right, so bag valve mask components. Let's go over the components of the bag valve mask a little bit more. It has a disposable self-inflating mask, a non-pop-off valve, or if one is present, the capability of disabling a pop-off valve. You want the pop-off valve on. An inline viral filter, right? That way, if your patient has like COVID or whatever, it's kind of protecting you with a filter. An outlet valve that has a true valve for non-rebreathing. Has an oxygen reservoir that allows for delivery of high concentration O2, a one-way valve, no jam inlet valve system that provides oxygen at a rate of 15 liters per minute, right? With a standard 1522 millimeter fitting adapter, right? That 1522 adapter is down here, right? That can be utilized for ET tubes as well, something that you guys won't be doing at all unless you're helping out. But that adapter will fit over an endotracheal tube connection. A transparent face mask, ability to perform under extreme environmental conditions, so it doesn't really freeze up on you. The volume of air delivered is based on observing chest rise and fall, right? So increase and decrease of the chest. And bag valve technique, we're going to cover all that and during practical sessions, as this is one of your skill stations under oxygen delivery and airway management. Gastric distension, we already covered. That's the big belly that we don't want. Occurs when artificial ventilation fills the stomach with air, most likely when you over ventilate a patient or forcefully push it in, right? You don't want to go too forcefully. You don't want to go too rapid, all right? Nice, easy squeeze. Look for chest rise. Too rapid, it will bypass down the esophagus, right? And then too forcefully will also push it right past it and not get the oxygenation that you need in the system. Each breath should take about a little over a second. So you count, squeeze, 1, 2, 3, 4, 5, 6, squeeze, right, over 1 second, release. Let that oxygen then suck back in and then fill in the reservoir bag, all right? So with gastric distension, ensure the patient's airway is appropriately positioned. Ventilate the patient at the appropriate rate and ventilate the patient at the appropriate volume. If gastric distension makes it impossible to ventilate the patient, an ALS provider is not available to perform a decompression, right? That would just be placing an OG tube or NG tube. Consider applying pressure over the upper abdomen as a last resort, pushing it back out. Again, this will cause vomiting. If vomiting does occur as a result, turn the patient's entire body to the side and suction or wipe the mouth out with your gloved hand. Do not stick your fingers inside somebody's mouth, all right? Don't do it. But you absolutely have to, like if you see an obstruction, like in a pediatric or whatever. But again, if you can't see it, you don't put your fingers inside of it. Return the patient back to supine position and continue rescue breathing for the patient. Clear the airway. If you have someone who's unconscious, not breathing with a pulse, suction should be out, on, connected, and ready to go. So as soon as it happens, you can start suctioning the patient out. Passive ventilation. We're going to finish up this one here and take 10 minutes. It'll be 8 o'clock by then. So passive ventilation is sometimes called passive oxygenation or apneic oxygenation. Air movement in and out of the chest cavity occurs passively as a result of compressing the chest. So when the chest is compressed, air is forced out of the thorax. As the chest recoils following compression, a negative pressure is created within the chest, which then results in a vacuum, sucking the oxygen back in from the outside. Air is sucked into the chest cavity, similar to what happens with the muscle contraction during active inhalation. Right? Passive ventilation can be enhanced by inserting an oropharyngeal airway or providing a supplemental O2. All right. Automatic transport ventilators, what they call ATV resuscitators. An ATV is a ventilation device attached to a control box that allows the variables of ventilation to be set. It frees the EMT to perform tasks such as maintaining the mask seal or ensure continued airway patency. Consistent reassessment of this patient is necessary. In New Hampshire, on a 911 call, EMTs are allowed to take ventilators on patients who have like trachs in place that are not newly intubated. If they are chronically on a vent, an EMT can take that in the back of the ambulance. Why is that? Because the family members coming with you are trained to use it. So you can take it as an EMT. You do not have to have a paramedic in New Hampshire to take a patient who is currently on a vent that is not newly on a vent. Now, if they're coming out of the ER and they're intubated with sedation medications, all that is truly a paramedic call, right? But a 911 call, a patient on a home ventilator, that is EMT all the way, right? Now, there may be other things going on that you can't treat that requires a higher level of care, but the vent itself can be taken at the EMT level. All right, let's take 10 minutes. We'll come back at 8:10 and we'll talk about CPAP. Like I said, this will be an early night, so. So how's everybody doing tonight?
Good.
Good.
You guys taking all this in?
Trying.
A lot. But
Deep breaths.
once you guys get the hands-on stuff going, a lot of this stuff will click. Right? You're gonna be like, oh God, I understand now. So it just takes time. This is like Zach was saying and Morgan has said too in the past. We're just laying down all the groundwork. This is all the ground material, right? The basics of what we need to do, the base of what we need to do at the EMT level. Once we get past all this airway management stuff and A&P and everything else that we're doing, we're going to start breaking it down into specific types of emergencies: respiratory, cardiac, neurological, and we'll break those down based on assessments. The medications we'll be administering as well, from glucose to nitro, aspirin, albuterol, duonebs, through nebulizers. There's a lot of different states that allow people to do that too as well. So it'll come to you. Don't worry. And we're getting more and more devices now as well. So
Kevin, I just have a question about the testing. I know that the written is at a Pearson, right? At
yes,
the different ones. And I've got to take mine in New Hampshire, and then I'm going to just do the what is it? That word to be in Maine.
reciprocity, yeah.
Yeah, correct. Now, the practical, where are we doing that for our testing?
So the written test can be anywhere. It doesn't have to be in New Hampshire.
I can take mine in Maine?
Yeah, the written test you can.
Okay, so then
Because
do we do a practical for the state?
the practical, it has to be done in New Hampshire. So what I recommend to everybody is once you pass the test, I give you clearance authorization, the test, go through NHCPR or New Hampshire CPR. All right, that's the name, that's a company, and they offer testing every month.
And they do the hands-on, the practical.
Correct. Those skill sheets that I gave you, yes.
Okay.
And you get 3 chances to pass it.
Mhm.
All right. So if you fail it a first time in one station, if they have time, they may let you retest to go back in and retest that same day. If you fail it a second time, then you get one more. If you fail it a third time, you got to redo them all over again.
Okay, so if you just fail one, you've got 3 tries to get through that one station.
Correct. But if you fail the one station 3 times, you have to do every station over again. Right. Okay. So what New Hampshire CPR does is they allow you to go in the day before. You pay a little bit of extra money, go in the night before, and they let you look at all the stations, and you walk through them, review them, and everything else. So that way there, when you go back in the next day for your testing, you already know what to expect when you walk in the room.
Where are they located?
They are not Concord. What am I thinking of? It's over past Concord, that direction, headed towards like Nashua. Bedford. Thank you.
Bedford?
Yep.
And it won't be a conflict if I take my practical in New Hampshire and because it's the National Registry, the written test is the same written test everywhere?
Correct.
Okay.
Eventually, next year, they're going to do away with all the practical skill stations. There'll be no more.
Why?
The instructor will do them in-house, like I'm doing with you guys.
Yep.
So I sign you off internally saying, yeah, they met competency. And all you have to do is take a written test.
Boy, that puts a lot on you.
It does, but you have to pass every station twice with me with 100% accuracy in order to pass the class.
Yeah.
So I've already started that. So if you can pass it twice with me and I'm a lot harder than they are, then you should have no issue whatsoever passing theirs. I really push you guys to be better than EMTs.
So if the New Hampshire The New Hampshire CPR does it once a month, so if we're finished on the 19th, chances are we could get into the December
Correct.
testing.
Just keep in mind that we're in the holiday season, so you got to find out when they're offering it.
So we should probably start looking now.
Yeah, take a look and see what they have. You just can't register it for it, I don't believe. Well, maybe you can. Maybe you can still register for it anyways beforehand. But if you're going to do it and pay the fee, you better make sure you pass the class.
Oh, yeah.
So, yeah, exactly. All right, let's talk about CPAP. Then we'll do some questions and answers at the end. So we're not going to take any more breaks from here. We got about maybe 40 slides or so, less than 40, or about 20 or so slides left. And then we'll get into the review questions. So CPAP, something that's new to the EMT level. I love CPAP, but I love BiPAP more, but you guys can't do it, right? But CPAP is phenomenal. CPAP is continuous positive airway pressure. Understand these terms. Continuous positive airway pressure. It's a non-invasive ventilatory support for patients experiencing respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP at night to maintain their airways while they sleep. Right? CPAP in the pre-hospital environment has proven to be an excellent adjunct in the treatment of respiratory distress associated with COPD, acute pulmonary, and acute bronchospasm. Right? Acute pulmonary edema, so fluid in the lungs. Right? It helps take that fluid and it helps shift it out. Pressure in shifts fluid out into the interstitial space. So, and what EMS has now called the term third spacing, right? It pushes that fluid out of the lungs and gets it out of there. Now, there are other medications as well to help with that, but you guys can't do that at the EMT level. But as far as CPAP goes, it's great for any respiratory condition that's severe. COPD exacerbation, patients get CPAPs. All right. CPAP is becoming widely used at the EMT level. Massachusetts, New Hampshire, and Maine all have it approved now at the EMT level. I don't know why it muted me. Mechanism. So CPAP increased pressure in the lungs, which it opens the collapsed alveoli and pushes more oxygen across the alveolar membrane and then forces interstitial fluid back into the pulmonary circulation as well. So it pushes it out of the lungs back into circulation to help them stop drowning internally. Right? They got to be able to breathe. Okay. I just had a question with this. So what's another name for alveolar collapse? Let me go back one step. What keeps alveoli open? This was covered in human body. Any thoughts?
Gases?
No. So you ever heard of something called surfactant?
Oh, yeah.
Yes. So surfactant helps with that. If you have a loss of surfactant, what happens to the alveoli? Right? They shrivel up, they collapse. What's another name for what's another name for alveolar collapse? Give you a hint because with an A. Anybody? All right. It's called atelectasis. Atelectasis is alveolar collapse. Usually to a lack of surfactant can make that happen as well. Right? So we're trying to open these alveoli back up again by providing that pressure. All right. I don't know why it keeps muting me all the time. There we go. All right. So the therapy is typically delivered through a face mask held to the head with a strapping type system. They have good strapping systems out there and they have really crappy ones, but there's still systems that are out there. A good seal with minimal leakage, shouldn't have any at all, between the face and the mask is essential because you have to maintain that positive end expiratory pressure. So what I just told you, and I should probably write this down, PEEP, PEEP, and not the little marshmallows you guys eat during Easter, right? PEEP is positive end expiratory pressure. So many CPAP systems use oxygen as a driving force to deliver positive ventilatory pressure to the patient, which means that they use high oxygen, in turn will drain your tanks faster. So you've got to be able to plan it out. Patients benefit the most from CPAP during exhalation. Okay. So use caution with patients with potentially low blood pressure, because remember, CPAP also causes a drop in cardiac output. So why don't we all create our own PEEP? How do we do that? What sign would you see in a patient trying to create their own PEEP before we apply CPAP? And I know I covered this with you guys before. What's a sign of a patient someone in respiratory distress trying to create their own PEEP?
Tripod?
Not
Pursed lip.
tripoding.
Or the pursed lip breathing.
Pursed lip breathing. Exactly. Right? So again, we did this before. Everybody took a breath in and out with their mouth open. The air comes out faster. If you purse your lips, it takes longer. That allows your lungs to stay open for a longer period of time. In turn, will then allow for the better gas exchange that is needed. Right? And if we were doing something with end tidal, and remember Zach mentioned waveform capnography, we're going to see something called shark fin, and we'll go over that later when I do an actual capnography class with you guys. I teach the capnography class all over the place. People love that lecture. So indications: the patient is alert and able to follow commands. You cannot put a patient on CPAP who is altered. They have to be able to maintain their own airway. The patient displays obvious signs of moderate to severe respiratory distress from a condition such as pulmonary edema or COPD. All right. We do not put it on patients that are asthmatics. BiPAP would be better for asthmatics than CPAP. Respiratory distress occurs after a submersion incident as well. So you're drowning victims. The term near drowning, we don't even discuss anymore. It's either they did not drown or they did, not near. All right. The patient is breathing rapidly, such as it affects overall minute volume. The pulse oximetry reading is less than 90. I don't like that term. Okay. I'm not a huge fan of saying less than 90. Because if I have a patient with a pulse oximetry of 87 or 88 and they're COPDers, I'm probably not going to put them on CPAP right off the bat. Now, if I walk into a room, pursed lip breathing, tripoding, accessory muscle use, and they have an SpO2 of 68% with good pleth, yeah, this patient's going to get CPAP pretty quickly, right? Again, it comes with experience and understanding how patients present. Contraindications: the patient is respiratory arrest or has abdominal respirations. The patient is hypoventilating, so breathing too slow. The patient cannot speak. Patient is unresponsive or otherwise unable to follow verbal commands. Patient cannot protect his or her own airway. And if the patient is hypotensive, right? Key thing right here, hypotension, right? If they're hypotensive, you're already decreasing cardiac output. Imagine what would you do if you put CPAP on a patient and decreasing even more cardiac output. You're going to put that pressure into the tank, right? And sometimes it's hard to recover, especially at a BLS level, it's hard to recover from that. All right. Contraindications continued here. So signs and symptoms of a pneumothorax or a chest trauma, which means you have to get a good set of lung sounds. If a patient has chest trauma, or they have diminished or absent lung sounds on one side, CPAP is contraindicated. Patient who has a trach, well, it's got a hole there, so it's not going to work too well. Active gastrointestinal bleeding or vomiting. Why? Because they're still putting pressure on the thoracic cavity, right? Or the lungs, right? So if the patient vomits, that CPAP will then push that right down their trachea, right in through the glottic opening, to the trachea, into the bronchi, to the bronchioles, right into the alveoli, and flood the lungs with vomit, right? The patient cannot sit upright. You do not lay a patient down. Patient in cardiogenic shock, right? They already have crappy cardiac output because of cardiogenic shock. Last thing we want to do is make it even worse. Patient has experienced facial trauma. Remember, you have to put the mask on their face and nice and tight. If the CPAP mask system does not fit properly, it's not going to work, right? Or the patient can't tolerate it. One of the biggest things we see in this, in applying CPAP to a patient, right, is going to be the patient being claustrophobic. So one of the best things you can do is allow the patient to apply it to themselves so they can truly feel how quick this actually does work, right? When we give a diet, let's say we have a patient hypoglycemia, what do we give them?
Glucose or sugar.
Glucose. And normally it works pretty quick, right? For the most part. I would say yes. It takes a little bit of time, but it works. D10 or D50 for an advanced EMT or a paramedic, it works pretty quickly. CPAP is like that. You apply it, you truly are saving somebody's life. There are very few things we can do in EMS to truly save somebody's life and see it make a huge difference. Glucose is one and CPAP's another, right? We can see almost instantaneous changes by applying CPAP to somebody and how they mentate. So components of the CPAP unit, they have a generator, a mask, a circuit containing corrugated tubing, a bacteria filter, and a one-way valve. The CPAP generator creates resistance throughout the respiratory cycle. That's your PEEP. The resistance creates a back pressure into the airways that pushes open the smaller airway structures, such as bronchioles and alveoli, as the patient exhales, right? This will allow for gas exchange to happen throughout the entire alveolar field. If they're off gassing at different times, that's when you're going to start seeing your shark fin waveform capnography. Right? So the amount of pressure can be determined by adjusting a valve within the CPAP system or a separate valve that can be attached. Every system is different. It could be just adjusting the flow rate. Will change the amount of pressure you get too. So again, you have to know your devices that you have. Some patients may find CPAP claustrophobic and resist application of the mask. So again, coach them through it. I've given as much as, for me, you give somebody some Ativan or some Versed, which you guys don't carry, and it calms them right down. But you guys don't have that ability. But if you're applying CPAP to a patient anyways at the EMT level, you should have a paramedic coming anyways, because it means they're pretty bad respiratory status at that point. Due to the high volume of pressure generated by CPAP, pneumothorax is definitely a risk. So high pressure in the chest can lower the patient's blood pressure as well. So if the patient shows signs of deterioration, take it off and start applying a positive pressure ventilation using a BVM attached to high flow O2, right? CPAP is great, but if it doesn't work, take it off and go to the trusty BVM. I like to call it poor man CPAP, but it works very well. Some special considerations: stomas, trachs, patients who have laryngectomy have permanent tracheal stomas. So the larynx removed usually due to cancer, which is an opening in the neck that connects the trachea directly to the skin, known as a tracheostomy. So again, if you have this, it's contraindicated. All right. All right. So if the patient has a tracheostomy tube, ventilate through the tube itself with a BVM. All right. The standard 1522 adapter on a BVM will fit right onto the tracheal tube, the tracheal stoma. 100% oxygen as you deliver through the device. If the patient has a stoma but no tube is in place, use an infant or child mask with your BVM device and place the seal over the stoma itself. That's that hole that I showed you earlier. Right? Seal the patient's mouth and nose with one hand and to prevent any kind of leaks of air through the upper airway as you ventilate through the stoma. Release the seal of the patient's mouth and nose for exhalation. So you literally have to put your hand over their nose and mouth and block everything. This allows air to exhale through the upper airway as well. If you cannot ventilate the patient with a stoma, try suctioning the stoma and the mouth with a French or soft tip catheter. It could be a mucus plug in the way. So seals the stoma, again, you can seal the stoma while giving mouth-to-mouth ventilations as well. All right. Airway obstructions, you guys, we're going to be covering this in depth as well during CPR on October 1st, as this was part of your CPR class. But if it completely blocks the airway, it is a true emergency. It will result in death if not treated immediately. So an adult, we want to do abdominal thrusts as long as they're still awake. If they become unresponsive, lie them down and start doing CPR, right? Pushing on their chest compressions. In a child, it can occur while eating, playing, small toys, or crawling around the house. By far, the most common airway obstruction in the unconscious patient is the tongue. Remember how Zach mentioned that before, right? Falls back in your airway. We have to displace that. By doing so, we can place an oropharyngeal airway, and that will allow us to displace the tongue. Swelling from an infection or an acute allergic reaction as well. Repeating attempts to clear the airway could also be dangerous. If we have a swollen tongue, the other name for that is called angioedema. All right, angioedema. Know that term. All right. So we get into pharmacology and we start talking about ACE inhibitors, all right, like lisinopril, that can cause significant angioedema out of the blue. Somebody who's been taking it for a long time, 5 years, and all of a sudden one day they take it, full-blown angioedema, tongue swelling up, and they can't have an airway. Rapid transport to the hospital is critical for these patients. Remember, and tissue damage from the injury, looking for trauma as well. Recognition of mild airway obstruction. So patients can be still exchange air, but are varying degree of respiratory distress. Great care must be taken to prevent any kind of mild airway obstruction from becoming severe. Right. So don't start jarring things around. Don't shove your fingers down their throat. Right. They have an obstruction. Let's get them to the hospital. Right. Have ALS coming, because we have something called McGill forceps that we can utilize with a laryngoscope to go in and pull the objects out. Patient may have noisy breathing, but also may be coughing, right? Coughing is good. We want them to cough it up. With good air exchange, the patient can cough forcefully to allow, although you may hear wheezing between coughs. If they're wheezing, it's not bronchoconstriction, okay? They have an airway obstruction. So just because you hear wheezing doesn't mean you start giving them albuterol treatments as a bronchodilator to open them up. With good air exchange, remember, try to coach that patient to cough forcefully. As long as the patient can breathe, cough forcefully or talk. You should not interfere with the patient's efforts to expel the foreign objects, right? And continuously reassess the patient. With poor air exchange, the patient is weak and effective cough may also have increased difficulty breathing, stridor, or cyanosis. Stridor being an upper airway issue, right? Keep that in mind. Upper airway is stridor, right? Wheezing, bronchi, rales, those are all lower airway. All right. But stridor is an upper airway. Also, you'll hear stridor as well in patients with croup. It'll be that seal bark type cough. Treat immediately as if there's a severe airway obstruction if this happens. Right? Universal sign of choking. This means help me. Right? Patient cannot breathe or talk. The patient may clutch or grasp for their throat. And the universal distress sign. They may turn cyanotic and have extreme difficulty breathing. A patient like this here, we're going to get them up off the ground. We're going to just go just above the navel or below the xiphoid process, hand over fists or hand over fists behind them and up, in and up, forcing that out. It's what they call the abdominal thrust, or in the days of Heimlich maneuver, but Heimlich has been removed now. Now it's considered an abdominal thrust. If they go unconscious, we're going to start high quality CPR. All right. I think we've already hit all this here. Emergency care for foreign body. Okay, again, if they're on the ground, use a head tilt chin lift maneuver to clear the tongue obstruction. If spinal is suspected, remember the jaw thrust. Large pieces of vomited food, mucus, loose dentures. If they have dentures in and they're unconscious, put your hands and take the dentures out. Right, they get in the way. Right, and then try to clear out the airway utilizing suction. Dental appliances, like I said before, crowns, bridges, dentures, pieces of braces. Don't start ripping braces off teeth, but if they're kind of just hanging there and they're loose, take stuff out. Dentures come out, right? This provides more structure to the face as well. Allows you to be able to get inside and be able to ventilate appropriately. Facial bleeding, airway problems can be, particularly challenging in patients with serious facial trauma, right? There's 64 bones in the head. We're not going to have you memorize 64 bones. I'm not going to have you do that at all. Understand the major ones, right? Most commonly fractured facial bone is what?
Either the nasal bone or the eye socket, the orbital socket.
Orbital, correct. Yeah. So the orbital is the most commonly fractured. They're also very thin. And what will we see? What kind of sign would that be called? What sign? What's the name of that sign we see?
Raccoon eyes.
Exactly. Right. So blood supply to the face is also very rich. Anything to the face and the head, we have high vascular, high capillaries, right? So anything small, even like a small laceration to the head, bleeds a lot. All right. So control the bleeding with direct pressure and suction as necessary. Again, if there's an impalement, we never remove anything unless it impedes airway. All right. So if you have a pencil through the cheek and the airway is clear, leave it in. If it's occluding the airway, we need to take it out. Other than that, we never, ever, 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 ever remove an impaled object unless it impedes the airway. All right. Assisting with ALS airway procedures. There's an acronym called B-MAGIC. Perform back valve mask pre-oxygenation, evaluate for airway difficulties, manipulate the patient, attempt first pass intubation, use a supraglottic airway if unable to intubate, and confirm success intubation with correct any issues. Right? So successful intubation, no epigastric sounds, positive lung sounds, misting in the tube, visualization through the cords. There's all these different things that paramedics have to worry about, right? But it does not happen quickly. If intubation is happening, it is a process, and it takes more than 30 seconds to do it, right? And since we're talking about this here, you're going to be pre-oxygenating a patient. Pre-oxygenation is also something that they call nitrogen washout. Nitrogen washout allows for patients to be intubated or that are unconscious, not breathing. We give them more oxygen than they need to wash out the nitrogen, give them more oxygen. That way there we can stop breathing for them for a longer period of time and it's not going to affect them. Right. So you're just going to follow the paramedics' orders.
Can you guys hear Kevin?
No.
Okay. Guess we lost him.
You disappear again?
Mhm.
Yep.
See.
Morgan, we're on slide 121. We're at the end.
Is that the last slide?
Mm-hmm. Oh, it's Zach. I'm sorry.
Oh, no, you're good. I came in and he was gone, so.
For the review.
is he was talking about doing innovation. I've never seen this before, I guess. So you're gonna pre-oxygenate, so there's more time for medics to intubate, and then if that doesn't work, then somebody's gonna do supraglottic airway, more or less. And then we're gonna confirm with either capnography, doing the little pop test thing, or listening to the lungs and look for chest rise, or different ways to do that. Any questions? Oh, you can't see my thing, can you?
We can see.
Oh, you can
That's
see
No,
the
I can
slide?
see it.
Yeah, you're on
Yep.
review, the breathing. Yeah.
Morgan, I
Oh,
brought
that's
it
really
up.
good. Okay,
Oh.
good.
Do you want to take over? And I don't know if you.
I'm back,
Sure.
but I'm using the hotspot on my phone now. My internet just completely turned off.
All right, Kevin, do you want to take back over? I pulled up the review, but
Yeah, we
gone.
were almost we were on the assisting with airway ALS procedures, but I can.
That was the last slide.
That was the last slide. Hey, if you want to just continue on, that's fine.
You
Morgan, if
had it
just
on
wanna
the
finish
screen, but
up.
now it's gone.
Hold
all
on.
right, hang on.
I can bring it back up. Here you go.
All right, you got it.
Yeah, I'm just using my phone, so I'm not sure where you guys were on the review.
We just
Just
said
started
we
the
just
first
barely
question.
started it.
All right, so we'll continue on. Literally my internet just shut off completely, so I'm using the hotspot on my phone. So hopefully that works. So Morgan, if you want, Morgan, you can run this one if you want. I'll just listen in.
Sure. So number one, breathing is controlled by an area in the A, lungs, B, brainstem, C, spinal cord, or D, diaphragm. That's a tricky question. B. Go with B. Any other
All right.
answers? Oh, yeah, I don't have control of that. B.
I do. I'll move it for you.
Oh, good. The pons and the medulla are the respiratory centers of the brainstem. So if anybody ever watched, what is that movie? Adam Sandler movie, the medulla oblongata. It's the caveman part of the brain. So that's what makes it automatic.
What a great movie.
Yeah, it's funny.
Waterboy.
The EMT. Yep, it is. The EMT should assess the patient's tidal volume by A, observing for adequate chest rise, B, assesses the facial area for cyanosis, C, counting the patient's respiration rate, D, measuring the patient's oxygen saturation.
I'll give it 10
Anybody-
seconds and I'll swap over.
Sure. I would say A as well.
All right. A it is. Perfect. All right, let's go to number 3.
In an otherwise healthy individual, the primary stimulus to breathe is an A, increased level of oxygen in the blood, B, a decreased level of oxygen in the blood, C, an increased level of carbon dioxide in the blood, D, decreased level of carbon dioxide in the blood. C, everybody's going with C.
See, it is.
Yep.
Yep.
Signs of adequate breathing in an adult include all the following except A, pink, warm, dry skin. B, shallow chest rise. C, symmetrical chest movement. D, a respiratory rate of 16 breaths per minute. That is correct.
B. Number 5.
During the insertion of an oral pharyngeal airway into an unconscious patient, she begins to vomit. The first thing you should do is probably take it out. A, turn the patient on the side. B, remove the airway at once. C, suction the patient's mouth. D, use a similar size oral airway. D is definitely out.
Oh, you got it wrong.
B. I would, yes, because contraindication is gag reflex, so you have to take it out. Then you roll the patient on the side, or
So
suction.
according to the review, the answer is A.
Oh,
Right. So basically, it's like Morgan's not wrong though. So if we have a patient who's actively vomiting, we're taking it out. It's kind of like in the same motion. We kind of roll and pull it out at the same time. But for test answers, though, it's going to be A first. Roll the patient to the side and then pull it out.
because you want to manage the airway.
Correct. All right, number 6.
But if they're going to puke that out anyway. So, in which
Right.
of the following patients would a nasal pharyngeal airway be contraindicated? A semi-conscious patient with a gag reflex. B, an unconscious patient with an intact gag reflex. C, a patient who fell 20 feet and landed on his or her head. D, an unconscious patient who gags when you insert an oral airway. C. Why? Why C?
Facial.
Facial. Yeah,
Trauma to the head, yeah.
it's good
It is.
indication for basilar skull fracture.
Number 7.
You're delivering oxygen to a patient with nasal cannula at 4 liters per minute. Then he begins to complain of burning sensation in his nose. You should A, remove the nasal cannula. B, apply a non-rebreathing mask. C, attach an oxygen humidifier. D, increase the flow rate to 6 liters per minute. I never had this one happen to me. Oh,
No.
we're split.
Yeah. So C. So
Yep.
dry oxygen is not good for long term. So one of the things you'll notice in nursing homes, they'll have it. Patients on a med surg unit, even in ICUs, that they're long-term ICU patients, they'll find a way to humidify that oxygen so that it doesn't dry out all the mucous membranes, causing significant, cracking and bleeding. So you'll see that.
It's strange because in the book they kind of talked about that the humidifying isn't a good idea because it spreads the droplets if they're sick. They kind of
Right.
steered you away from thinking that that was actually the answer by what they had in the book.
Correct. But the thing is though, is that even in pre-hospital medicine, this is more real world stuff.
Mhm.
We don't even use this anymore. And there was a service I worked for about 15 years ago that used to have heated humidified oxygen. And it was one of those things that was allowed in the state of Maine for a little bit, and then they pulled them off the trucks. But it worked very well for patients that were hypothermic because it heated their inside. It was amazing. But the state pulled them off because they didn't like the equipment on the trucks. I'm not sure why they did it.
So I guess I'm confused as to why the answer would be C if in the real world we're really not going to.
Because the national standard still allows people to do it.
Gotcha. Okay.
Yep. So number 8.
A patient is found unconscious after falling from a 3rd floor window. His respirations are slow and irregular. You should A, place him on the recovery position. Oh, no. B, apply oxygen via non-rebreather. C, suction his airway up to 15 seconds. D, assist his breathing with a bag mask device. This is kind of a tricky question.
It is, but you can break them right down.
Yeah.
So
Everybody's going with
recovered.
D.
Yep. I go with D2. Why
Yeah.
suction something that's open? The guy's breathing too shallow and irregular, so we got to assist. And we don't turn him in recovery position because it could be a spinal fracture.
Yep.
We just got to break him down. This is what the national registries will do to you. So the answer is D. Number 9.
When ventilating an apneic and adult with a bag mask device, you should squeeze the bag A until it is empty. B over a period of 2 seconds. C at a rate of 20 breaths per minute. D until visible chest rise is noted.
And I hit this one a lot during this lecture.
D. Yes,
All right,
I would go
D
with D
it
as
is.
well.
Number 10. Last one.
You and your partner are ventilating an apneic adult when you notice his stomach is becoming distended. That's how I met my wife, actually. You should A, suction his airway for up to 15 seconds. B, reposition his head. C, increase the rate and volume of your ventilations. Decrease your ventilation rate, but use more volume. I'd go with
Yeah, I'm hearing a lot of
reposition
B's.
his head.
Yeah, B it is. All right. So before we turn off recordings and all that, let me end the show here. That's better. All right. So that is all I have for you guys tonight. So it is 8:47. So definitely a lot earlier than it has been the last couple of classes. Don't get too used to this because we have a lot of material in a short amount of time to cover. Please make sure you keep up on your quizzes. Okay. Make sure you get those done. Make sure you get all the other things, the soft skills, the virtual mentor series. Start watching those. I know we still have 2 months left, but eventually it'll be a week left. You'll be like, oh crap, I didn't get it all done.
It
All
took
right,
me
so
all
you wanna
day
be-
Saturday. It took me all day Saturday to watch all those movies, those videos online. So